Before we start, let me ask you a question. You can already answer on the Q&A, so we can already try it. What will be the most important event of 2030? Do you have an idea? I'll give you 10 seconds. I think it's pretty obvious. World Cup, okay. What else? Okay. Well, as expected, some of you might think of the Football World Cup, and we will be a part of it as a country. Of course, this is one of the greatest sporting events in the world, and yet it will be a highlight. But for us, it will only be the second most important event, because the real milestone will be the launch of the World Sim Cup. This is a unique initiative that was born from the collaboration of the three simulation societies representing the countries that will host the World Cup. And I'm very thrilled to announce that the official announcement of the World Sim Cup will take place in Murcia on December 16, 2025. We cannot wait to discover this beautiful city, explore its state-of-art simulation center, and reunite with our affiliated societies, Portugal, SPCIM, and Spain, CICEP. As for today, we have prepared an exciting program for you with 4 sessions dedicated to the culture of safety, simulation integration, human factors, and my favorite part, innovations for the future. At the bottom of your screen, you can activate the live transcriptions for accessibility. And please remember, you can use the Q&A section to post your questions. Our chairs will collect them and will try to facilitate discussion at the end of each talk. We are also live streaming this conference on our website. It's www.moroccosim.org, or you can go to our YouTube channel under the page of MoroccoSim. Finally, thank you very much for joining us. We wish you an excellent and enriching webinar. Together, let us begin our journey from errors to excellence. It is now my great honor to give the floor to Professor Norm Kawi, who will chair our first session. Professor Norm Kawi is a professor of pediatrics at the Faculty of Medicine and Pharmacy in Rabat, specialized in pediatric emergency care. She is also a board member of MoroccoSim and is strongly committed to advancing simulation in healthcare as a powerful tool for education, training, and patient safety. Professor Norm Kawi, the floor is yours.
Thank you, Miriam. So welcome to session 1, From Errors to Excellence. Each speaker will have 20 minutes for their presentations, followed by 10 minutes for questions, and let us begin. It's my great pleasure to introduce our first speaker, Professor Sharon Weldon. Professor Sharon Weldon is president-elect of the Association for Simulated Practice in Healthcare and professor of healthcare simulation and workforce development at the University of Greenwich in the UK. She's a nurse and a researcher with expertise in surgery, infectious disease, global health, and simulation. She is internationally recognized for her pioneering work in sequential simulation and transformative simulation. Her presentation today is entitled, What Makes a Strong Safety Culture? Professor Weldon, the floor is yours for 20 minutes. Professor Weldon, are you here? Maybe we can start with the second presentation and then come back. I think she has a problem to connect. Miriam?
She's here. I will just send her the link again. We just need 2 minutes.
I think I can see her in
There.
the...
Hi everyone, sorry about that. I was here, but I didn't have any access. And I'm on my phone because my laptop broke, so bear with me. Thank you. Lovely to see you all. And thank you for the introduction. And while I'm getting started and trying to share everything, I just want to say thank you for having me. I really think Morocco Sim are doing some incredible stuff, incredibly creative, really forward thinking and very collaborative. And I just completely inspired by it all the time. So let me just see if I can share from here. No, I don't want to share that. Bear with me. Right, it's only let me share certain things. Try this.
Sharon, if you want, I can start and give you some time to.
Thank you, Francisca. Would you mind? That'd be amazing.
No worries.
you.
Great to see you.
You too.
So I can introduce you, Professor Francisco, who is a director of the anesthesiology department, Coimbra University Hospitals, and a professor of anesthesiology, University of Coimbra. He's a president of Quality and Patient Safety Simulation Center coordinator at CHUC and Portuguese representative at the EBA UEMS. Professor Matos was former president of SPCM from 2011 to 2017 and former president of CESAM until 2024. His presentation today is entitled Beyond Blame, How System Thinking Prevents Harm. The floor is yours for 20 minutes.
Good morning. First of all, thank you very much for the organization for inviting me for this another fantastic event of Moroccosin. And it's my pleasure to be here amongst friends, and it's great to share the floor with Sharon again. So let's start. Let me share my screen. And thanks, Sharon, because usually it's me that has all these tech issues. So it's great to change sometime. So so let's start. I was asked to talk about not only the culture, but also to another way of thinking, not the system also, but healthcare. So let's go into it. So patient safety faces a lot of challenges today. The first, and we know the impact that patient safety has on healthcare systems, and we know how many people suffer from a non as safe as it could be system and healthcare. And we also know that patient safety is one of the leading causes of death in many developed countries. But the approach that we've been having for some years now on how we learn from healthcare system and healthcare paths have been changing for a more understanding, comprehensive approach in order to understand healthcare complexity. A lot of things are changing. We have migration issues that changes healthcare human resources from one week to another. We have educational pressure under the system. We have a system that is evolving in terms of measures, of indicators, and patient safety is just one, and probably it's the most important one, but from many management approaches, it's just one of the worries and not the main worry. So we are proposing here is a change in the focus on the approach that we have for understanding errors, adverse events, in order not only to understand and to learn from them, creating a safer and a more resilient system, but also in the way that we look and approach the system itself. So our traditional focus from some decades ago were really focused on the individual performance, and from the individual to the team, and from the team to the patient. So what we are proposing now, it's an understanding of the system, and each individual has part of a system path, and trying to understand the links in order to, on acting on the links, have building a safer and more resilient healthcare resources for all. But we still have a problem with the culture. We still tend to try to assign fault to individuals for errors and adverse events instead of examining the underlying system issues. Most of the responses are not on the pattern, on the path, on the trend, on the system, but also on the individuals and the teams, which creates a culture of non-understanding and many times a culture of fear that prevents an atmosphere of understanding and an atmosphere for growing. And the consequences of this, it's one, the underreporting of specific learnings situations that we could have to build a better system, but also it's also important in terms of even healthcare sustainability by itself. Not sustainability as a all resource, but also in the way that we create a more stronger workforce within healthcare system. Because this system prevents from creating a learning environment, a safe learning environment, but not just that, prevent us from creating a more empowered healthcare resources. And one of the most pivotal examples that I can give you is the medication errors, which is one of the most frequent errors that we have on medicine, on clinical setting. And we know from that even being one of the most frequent, it's also one of the most underrated reported errors, which prevent us every day from understanding what were the links that were missing in order to prevent this specific individual or team to have such performance. So in the blame culture, we don't just lose the opportunity to learn, but we lose the courage to speak up when the patient safety is at risk or where we identify a learning opportunity. So what are we changing to a systematic approach? First of all, the focus. We are emphasizing here the process and the system rather than individual blame. Trying to understand how each one of the peers, which one of the teams, which one of the departments connect in order to create complex relationships, roles, tools, decision making, and in the end, performance with the patient. And with that, understanding the process, understanding the connections, trying to understand the missing gaps and where the link fails in order to continuously improve in a more quality round circle of continuous improvement and quality and safety. So this framework tries to create a highlight on the importance of the interdependencies for the creation of a robust system. From the clinical inputs to the patient outcome, we understand how the process of the care was taken and what learning messages we can take in order to improve the system. Not in a overall perspective, but acting on the missing links. That sometimes could be simple, could be more complex, could be more interactive, less interactive, more related to educational gaps, more related to administration support, but identify these specific links that could make a huge improvement in the system, which comes to the 5 C's of system thinking. Curiosity. And curiosity is about always questioning the assumptions that support our performance, which is very important, creating and changing from a system where we do what we've been told, where we do what we have been seen, or we do what we always have been doing. Clarity, trying to see a bigger picture, take a step back and to understand the system as a whole. Compassion in a way that we need to understand each specific role, the pressure, the context, and even the emotional side of each specific performance. Have many options and consider the different options in order to approach the most efficient one. And sometimes it's not the first one that we take, but it's the one that we fine tune to be the most effective. And courage to make this change and to implement different actions when they are needed. So learning from errors, it's difficult because first of all, we need to have the signals from the system. We need to understand and to highlight not only just the weaknesses, but also moments that could be of good performance, of good outcomes, that we can take as learning messages and to build from, and to promote the moments of good performance and trying to improve where we could have been a lot better. And this creates resilience in the system in order to make from each incident an opportunity to build a system resilience and prevent recurrence. And these learning moments can be very powerful and can even strengthen the whole system in a way that all of these messages, all of these different understanding of things can be translated into clinical practice. And going again to another example, we have many studies, and we have one very recent one that demonstrated us that a system approach can be better in terms of error reporting, enhance team communication, and improve infection control. And even prevents variance by 2/3. And we know that variance is one of the biggest opponents to safety. So what can we do practically? This is where simulation can help a lot. Can help in the moment where we are performing, where are educating, where are we in the mindset for growing in terms of knowledge, in terms of competencies, but also in the way that it changes your mental model when you go back to the clinical practice. It's not just by creating realistic scenarios to practice teamwork, communication, to empower speak up, and trying to replicate all the pattern of the patient through the system. And Sharon, for sure, will talk a lot more about that in the presentation, but also to create a safe learning space and to create this safe culture where we are promoting a blame-free environment to explore errors and to explore the system by itself in order to create opportunities for growing. And this approach, it's also important when we define specific moments of the path, of the pattern, of the system, where we can find specific actions to improve the system, not just for safety, but also for outcomes. And this changes also the way that we look at the way that we perform clinically. And trying to remove the pressure for each individual decision making in critical moments, reduce the pressure on acknowledging knowledge at 1 second, at creating this leadership process when we have already a diagnosis made. It's important when we are creating a different approach, a broader approach, where we are reducing and transforming individual experience into a systematic approach, in a reliable process that protects the patients regarding of who is taking care of them and regarding of how complex the system is and how pressure the system has. So we need to train communication and not just train communication in an individual, in a team level, in a management level, and in the department level or a hospital level, but also create the tools for when each one of these clinician or non-clinician go back to their professional setting. It changes the mindset in order to approach difficult conversations, in order to approach a more specific analysis of the situation that they are faced with. And being more specific about it, we have many tools now of clinical debriefing and non-clinical debriefing that can be used in a daily basis that for sure will help, in a way to promote this more open and learning environment. So in a more organized way, so we come from the incident reporting to understand the pattern, and understanding the pattern and this path. What we try to understand later is how we can predict a mistake and how we can make the system and the pattern more reliant to each individual performance. And that's why we need data. And I give you another example, and this is, I promise this is the last one. And this is the example that is published about a dialysis center infection control. This is very well known on quality control and infection control. And it comes from an approach trying to understand each specific performance and individual performance when the infection rate was growing, in a way that for sure it's about cleaning, it's about somebody is not taking care of specific processes. But understanding more the system was really a broader perspective, in a way that how the fluxes of the visits, how the patient were called at each specific time, how inefficient the patient flow was, and how inefficient was the communication between the professionals. And this broader patient intervention made a higher and a more impactful intervention on the system than the specific and individual approach by itself. So we are changing the system from a fear to openness, replacing this blame culture to a more transparent, collaborative, and a more active approach of professionals that we need to empower, and not only on the way that they can know that their voice is heard, but in the way that they need to be addressed as a witness of the patient promoting their own safety. And this collective ownership of patient safety is important to grow a safe environment. And we also know that the main focus should be not just on the outcomes and on reducing the adverse events, but on reporting. We need data. We need data from the patients. We need to have the clinical path. We need to have the management path, and we need to have reporting. If we don't have reporting, we cannot intervene on the system, and we cannot empower the professionals that were involved in each specific moment for the growing of the system. And this is where well-being is so important. And we already know that this empowerment of the professionals is also important, not only for growing and for designing a specific path, which is not just educational, but also in the all spheres of their professional growing, but also on the emotional support that they feel when they are empowered in being an active voice, not just for the patient, but for the growing of the system. So we need to change, we need to face the resistance to change, understanding the training gaps, and we are facing human resources shortages. So this is something that it's very important on departments, on simulation centers, but it's also important on the departments trying to have interconnections between different professions, on doctors, nurses, all the system, but also on disciplines. And we already know that this is being changed from different approaches that we have on the hospitals, such as enhanced recovery systems for each specific patient path. But still, we have moments in these paths that are attributed to departments or services, and we need to make them more dependent on the path than on each one of the individuals involved. But for that, we need commitment for the management. We need to acknowledge this for the decision makers of the hospitals. And this leadership modeling can only be done if we really can translate this modeling into education, into an interprofessional approach in order to promote change and promote continuous support by creating a progress management, which is continuous, and in the end, it's a never-ending story. So from this approach, what we learn from is that we really need to change our mindset and change it from the foundation and change it in a shared way with a shared responsibility, empowering each individual, but also having a lot of responsibility to the decision to promote this system and this systematic approach from every professional to the top of the decision making in the hospitals and in the institutions. And we know that this doesn't come just by itself. We know that we have many things happening in the hospitals, and for sure, all of us that we have different roles in the hospitals, but all connecting with the administration, with the quality and safety, with the infection control. We know that the system, instead of becoming simpler and connected, it's becoming more complex, because this comes on top of this shifting from volume to value, from paths that are related to conditions, not just for areas, but not just patient-centered, but also path-centered. So many things are happening in the hospital while we are trying to promote patient safety, which makes the work a lot difficult. But this is why we are here. We are here to reflect, to promote speak up, and to collaborate. And we cannot have a better society promoting collaboration than Morocco SIM. So thank you very much.
Thank you. Thank you so much. Thank you very much, Professor Matos, for this excellent contribution. And we are now open the floor for 10 minutes of questions and discussions. Is there any questions? I would like to start just a little question. Have you tried to implement this thinking in yourself, and what were the common barriers you were to deal with?
We have been trying to promote this shift for many years from now. The first main barrier, it's a very specific barrier. That's why I haven't referenced to it in the presentation, which is how we align the culture and the mindset in the hospital, for instance, with the legal responsibility and the interconnection that the understanding of the management has of the same process. So even if we have the president of the hospital aligned with it, we have the management system still based on a different setting. So we need to change all the system approach to this system related understanding, which is very complex because in the end, we live talking about innovation, but we are facing a very different reality wherever we work in terms of what are the goals, what are the objectives, where are the metrics of performance of the hospitals and of the departments and of the SIM centers. And we are not still looking at how the patient came out, how the link was improved. It's still how many patients were done and still how many physicians you have. So we are still very, very behind in this process in order to be aligned by our mental model. So we need to push them to us in order to have this approach on the administration. And this is why we educators and healthcare professionals cannot be away from the management because otherwise nobody understands each other. So we need to push this message to the decision makers, to the management decision makers.
I have a question here. Sorry, I have a question here from the assistants. To promote data and incident reporting, there has not be non-punitive reporting. How can hospitals ensure reporting? What is the role of whistleblower policies?
Yes, first of all, it needs to be confidential.
Mm.
And secondly, you need to have at least at the hospital, because sometimes the legal context of the country is different, but at least at the hospital have a procedure to prevent responsibility, legal responsibility from the reporting.
Okay.
In order to have the reporting has a learning opportunity and not just trying to address individuals in this way. Which can be very, very tricky because you need to promote the reporting for the safety culture, not just for the report by itself. And to create this in the mental model, it's important. But at least you need to have a procedure when you start a reporting system. We have done it 10 years ago, and we started by that.
And I have a question in that sense. And do you have any validated instruments in your institution to access to safety culture?
That's a very, very broad question. I think safety culture, it's about mindset. It's not just about what you write, because I'm pretty sure that on most of the regulations of the hospital, you already have it. Like you have circular economy, like you have environment sustainability, like you have a lot of jargons, management jargons that you need to have. But the way is how you implement it, and you have it on the mindset, and you have it empowered in your own professionals. So I think it's not just about the procedure and having documents. It's about how the documents demonstrate a real culture inside your institution. But for sure, we need to have umbrella to perform this change.
Yes.
But I think that the umbrella should be, instead of main objectives, it's project-based change. So you need to have action, education-based action, management change procedures. Bring your administration to your sim center. Show the sim center. So what is done, instead of just being, instead of the external way about being really fun and being very attractive and really robotic and innovative, how it changes the communication. Have a specific examples where it changed their own performance, in their own meetings, in their own understanding of the other. I think that's a lot more powerful.
Thank you, Professor Francisco Mayo, for the answers. You can read and answer the questions by, there are a lot of questions. So now we'll go to our Professor Sharon Weldon. So Sharon, we'll talk about what makes a strong safety culture. You have 20 minutes. The floor is yours, Sharon.
Thank you very much, Noor. And thank you for kindly stepping in, Francisco, in my time of need. I think that's like the best example of adaptive teamwork right there. And actually, what you just presented, I think, should have gone first, because it kind of leads really nicely onto what I'm going to. I think you've really set the stage and the scene for me. So thank you. Appreciate that. I think Miriam's sharing my slides. So I really appreciate that, Miriam. Sorry. And yes, so I'm going to talk about what makes a strong safety culture. And as Francisco said, it's such a big topic. It's huge. Culture is everywhere. It's amongst us all in, we're all part of multiple cultures at any one time, whether that's our cultures within our countries, within the places we work, within our families, within our friendship groups, even within football, there's cultures. They're everywhere. And they're really important to how we come together, how we communicate, how we have a shared identity and purpose and feel belonging towards each other. So it's so important, and I don't think it has been given enough attention over the years. But let's kind of get into the nitty-gritty of what that means in healthcare more generally, and then we can talk about simulations. So we go to the next slide, please. So what we do know about why safety culture particularly is important. So safety culture is thinking more about, it's obvious, and and Francisco's talked a lot about it already, in terms of it's making sure that we are not harming our patients, that we're reducing error, that we're creating a healthcare system where people go in coming out healthier rather than come out with more harm. And it's quite frightening, because we know from the World Health Organization that at least 1 in 10 patients are harmed during hospital care. And we think that's from data only from high-income countries. We think data from middle and low-income countries would show that is much higher. And we know that at a minimum, 3 million people a year, but it's probably a lot more again, are harmed in healthcare. And considering it is a real paradox, because considering that we aim to, care for people and create better health, we're actually harming them at the same time. And most of this harm is preventable. That's what's so shocking about it and so hard. And what is hard about culture is that we do get really entrenched in our systems and way of doing things, because it is such a complex system. And we've all heard it a million times. And I think that's why a lot of us are in simulation. But this is the way we do things around here. Anytime you try to make change, anytime you see a problem. And really, change is difficult. And it is really hard to get groups of people together to really want to do something collectively for the better. And it's not because people aren't good people. It's not because they don't want to. We're all in healthcare because we want to do good healthcare. but it's complex and people are struggling with a lot of other things on their mind and things to, tasks to do and a lot of pressures. So how do we actually create a strong safety culture? Well, the biggest thing is having, and again, Francisco talked a lot about this, but not having a voice, not having fear, being able to speak up, being able to feel that we create a culture where people can speak up and be heard. And there's no right or wrong. It's a discussion, it's a debate, and we can think about these things. And that takes, everyone buying into that. That can't be, we just say it, we have psychological safety. Everyone has to be bought into the fact that everyone has a voice and everyone should be heard. We also really need that shared purpose and values, and people really underestimate how important values are. If you can't all get aligned on your values, you're in opposite directions. You're thinking completely different. They underpin everything we do. And they can actually be created quite easily when you come together and identify what they are. And when you know what they are, and everyone has shared values in some way or another, but when you know them, it's easier to move things forward. And it's easier to see what your ultimate purpose is. And in healthcare, those values are often, they're always similar worldwide. It doesn't matter what country we're in, what health system we're in, what profession we're from. Our values are very much the same. We just need to really be explicit about them. And we also need that continuous learning. And again, going back to what Francisco said, things are changing. It's complex in healthcare. We will never know it all. It doesn't matter how experienced we are. It doesn't matter how much research we read, how much practice we do. We are never, ever going to keep up with this complex, changing world and system. And so we have to be continuously learning, continuously humble, and recognizing that some of the newer generations coming in know a lot more about the world currently, especially with technology and AI and everything. And we have to be humble to that and want to learn from them as well as they want to learn from us. So it's that constant thinking that we don't know it all, we're all learning and we're all adapting in this complex system. And that also brings us into having transparency and trust. We need to trust each other. If we don't have that trust, it's really hard to get things done. You need to feel that you're part of a team, you're part of a system, you're part of an organization that wants to do good. It wants to do what you want to do, have those shared values. And that trust means everything. It means you can relax into your role. You feel that everyone's trying to do the right things. And if everyone's transparent in what they're doing, that really helps build the trust. And as Francisco's already talked about, the systems thinking, we haven't been so good historically with systems thinking, but there's a real shift more recently that we're all starting to understand the importance of it, that it's not just about individuals, it's not just about teams, it's much bigger than all of us. Next slide, please. And so, again, this has already been discussed, but there is this real, we have lots of frameworks out there already that's helping us to understand systems and culture and how we do it differently. And there's been lots of research poured into it and, some great stuff coming from human factors and different areas as well. But the problem is how do we actually get it from, and again, Francisco said this, how do we get it implemented? And how do we go from it being, a policy in a binder or a really good theory that people talk about to actually living it out in practice? And that is the real challenge. We understand what's going on. We know a lot of the problems. We have huge amounts of intelligence and knowledge in this area. We're just not getting it into practice. Next slide, please. And so this is where simulation is a bridge. And I know I'm talking to the converted here, but I think we all can see the potential and the opportunity for simulation to do this. Part of our problem isn't what we can see, it's more externally. And again, going back to Francisco's point about management, the decision makers, we have to help them understand the power of what simulation can do. And we have to have more clarity and be clear on what it can do, because it's an incredibly complex thing, simulation. I think we've tried to simplify it over time, but actually it's as complex as healthcare and more, because you add on the fact that you are trying to replicate or reimagine healthcare, which comes with all sorts of creative design thinking. And at the same time, you're using all sorts of approaches, technology, simulated patients, storytelling, everything to do that. And so it is really, really complex. And we have to start creating the structures around it to show people what it can do, really. So next slide. So as already been said by myself and Francisco now, we're moving beyond simulation and have been for quite some time, being more about skills, training, and even education. We're starting to see now how it can affect systems, culture, and even the leadership. and it can do so much more than I think we ever have given it credit for historically. It allows us to really reveal hidden risks and strengths. It helps us to kind of reimagine the future collectively, work together to think and play with systems, play with everyone laughs when I talk about simulation as play, but it's what children do to learn. They play to see how it feels to be a doctor or a nurse. They want to see what it feels to be like in the world in a certain way. And as adults, we need to do the same. We need to play. We need to know how things feel. What is our approach, how it feels amongst others, how our actions and our approaches affect others, how the system affects what we do. And that's where simulation is a lovely environment to do that. We can't do that in the fast-paced real world, but in simulation we can. So next slide. So talking about trying to help us understand simulation more in terms of what it can do, we have all sorts of approaches popping up, and over the years, there's been wonderful systems and frameworks put in place. We understand simulation for education really quite well now, and we understand the pedagogical learning theories behind them and how we can design them effectively to really get the learning outcomes we want. But when it comes to making change in healthcare, people have been doing lots of really creative stuff all over the world, but we haven't really brought it together to understand how that works and the impact it can potentially have. Well, we have now, but we hadn't for a while. And so what we did with transformative simulation is we looked at all the work that was happening globally to make change in healthcare, to affect our systems, change our cultures, all those things. So it wasn't simulation to educate and to tell people how to do best practice, because we're saying, well, we don't really know the best practice. We know things aren't working. We need to work together collectively to find a new way. And that's a very different lens when you're designing simulation. If you're designing simulation for education, you're telling or showing people and assessing them to see if they can do it in the way that is the best way we know how. When you're designing simulation for change, you don't know the best way. So you can't put learning outcomes because you don't know. What you're actually doing is trying to understand how you bring people together to make change. And we saw this and we came up with a definition that simulations transform health and care through collective insight and learning. So it's about bringing everyone together to learn together at the same time to generate change and have impact on the systems we work in and the cultures we're working within. Next slide, please. So how does transformative simulation really build a safety culture? Well, transformative simulation helps us look at what our intentions are when we're trying to do simulation for change. And it's built on the global literature. It helps us identify the theories we want for design and the processes and everything. But it does a lot more than that. It really does help us build a safety culture, the framework itself. And I'll talk you through why. Next slide, please. So what we start off with within the framework is the 5 foundational pillars, and these are really our values. And it's saying that if we're going to use simulation to make change, what is the purpose and why are we using it? We've all been in situations where we're asked to use simulation by someone because they think it's a quick and easy way to solve a problem. It might not be the right tool. And we need to make sure that we've got the purpose really clear and what we're trying to do with it. Are we trying to improve an existing system, or actually are we coming in with something completely new? Or do we not understand what the problem is? Or are we trying to engage more staff to make them feel more empowered? There's so many different things we could do with simulation. We need to understand the purpose. Sorry, next slide, please. So really what we are doing is, what changes are we trying to create? What's the purpose of the simulation and how are we going to make change? Next slide. And then we move on to perspective. So who is shaping the design? What voices are missing? We know that when we simulate, if we don't get the right voices involved, then it's a real problem in the sense that we're not actually going to be able to simulate what we need to, and particularly understand, if we're trying to make change, the problems we need to. So that's a really critical element in thinking about it. Next slide. And then power. If we're actually going to try and make change, can we make change? What systems and hierarchies is in place? If we find all these problems, is there even a possibility to make any change at all? And that's something we don't consider. It's all very well doing this, and simulation can be very resource intensive. But if there's no opportunity to make that change, then is it worth doing? Next slide. And then preparation. Are we actually designing this simulation to set the scene for authentic action and engagement? Are we setting it so that everyone is involved and they know that this change is coming? And the next one, please. and then possibility. I think really that is for me why simulation is so powerful, because we can actually kind of invite the future through simulation. We can see what it looks like, and we can see the possibility of what we can be and what we can do. And it's so exciting. So these are our 5 foundational pillars of transformative simulation. They're what we start thinking about before we even start the simulation. The simulation-based intentions, which are based on the literature and all the creative ways people are using simulation for change, have really kind of separated everything into clear objectives, because it really affects the design. So it's really important. So we have simulation for innovation, which is really about introducing new things, like maybe a new piece of medical equipment, for example. And then we have simulation for improvement. So that's kind of, if you've got something you might want to decrease waiting time, something like that. So you've got something that exists, but you just want to improve on it. You've got simulation for intervention. It might be that you don't really know what the problem is, but you want to use simulation to try and identify it, address it. Simulation for involvement. This is involving patients and people who don't usually get involved, so we can understand why, because they're part of the system. Sometimes the system doesn't work because of them, because they don't understand how the system works themselves, or there's a problem at their end. Then we've got simulation for identification, looking at latent safety threats, for example, identifying issues that are there. Simulation for inclusion, bringing in the workforce, helping them to make changes, really thinking about their well-being and empowering them to be part of change. And then simulation for influence, so influencing culture, policies, and I've got some great examples from the literature of how simulation is actually used to influence change at management and leadership level. So these are our 7 SBIs. And then why they're important is when we're designing the simulation, they help us align the theories and models alongside them. So, for example, simulation-based improvement, we've got a lot of the typical PDSA cycles that we see in improvement science within our departments, within our hospitals, etc. We go to the next slide. I'll zoom in on a couple of the other ones, so I haven't got time to go through them all. Next, that's it. Yeah, thanks, Miriam. So, for example, with the innovation one, we might want to use implementation science as the kind of backbone to help us design the simulation to implement something new. And there's lots of other theories we can use there. For the identification one, we might want to use some of the SEEPS models from human factors, or there's other models too, to identify different problems. And then with the inclusion one, for example, we might want to use some of the more human relation models and models around well-being and how you empower staff. So what these do, these intentions, is they just help us to really focus intentionally, design intentionally, effectively and impactfully. So we're not just, as our kind of current model is always we replicate reality, but actually we need to be more intentional. There's so much we can replicate in reality. We often can't replicate it all anyway. But what are we trying to focus everyone in on so that we can make change? Next slide, please. So now you can see the frameworks building. We've got our values, our five foundational pillars. We've got our intentions. What are we actually trying to achieve to make in this simulation that's going to make change? And then, next slide, please. We have our process. So in order to do it, we need to start thinking about how do we align the design, delivery, the data we need to collect, and the debriefing. And having this framework has really opened up for us what we're missing as well, and what we do have. So if you go on to the next slide. So yeah, design, we align the design to our simulation-based intentions, those theories and models that we saw. And then with the delivery too, that helps us decide what modalities, what settings, what participants need to be there. And the theories really help us make those choices. It helps us understand what data we collect, because we can align them with the theories. So if it's human factors, they already have data collection tools that we can use alongside, for example. And then debriefing, it helps us understand what debriefing methods will help us actually get the information we need for that kind of explicit collective learning that we can then feed back into the system, not implicit learning of how did you learn as an individual and change, but it's a collective learning. Next slide. So really, if we look at it this way, the intentions shape the 4 Ds of process, the designed. So if I give a quick example here, we often see that people don't have just one intention. Sometimes they do, but they might have a primary, secondary and tertiary. So you might, let's go with an example of implementing a new piece of equipment. So that's a simulation-based innovation. But at the same time, you want to know if implementing that new piece of equipment will create some latent safety threats. So you also bring in some theories around simulation-based identification. And then you might think, do you know what, I need to involve the patients in this because this is going to change the pathway and affect them. So you also bring in some involvement theories of how you effectively bring in patients into your simulation. Next slide, please. So we have this beautiful framework. It's powered by us people. It can't happen without us. It requires us at every stage to make these decisions, to work together collectively and collaboratively as a culture under a shared purpose. But it creates that framework to help us move forward and have a culture of this is what we do, to show externally what we're doing as well, not just internally, so we can be clear on this is what we're able to achieve with simulation to the managers, to the decision makers. And I'll move on from it now, but just anyone who wants to know more about transformative simulation, please go on the ASPE website, lots of free resources, and we want everyone to join and be involved. So we're always providing more resources, and we have a specialist interest group as well, and that's open to everyone. So why simulation is uniquely powerful for culture, safety culture? It is a real space where you can create honesty, you can create that transparency and start developing trust amongst people. It makes the invisible visible. It builds all that empathy and trust. It creates reciprocal illumination. We all think we're on the same page because we work in healthcare, but we all train separately. We all come from very different backgrounds, and we don't always see the system or what we're doing in the same way. And simulation helps us. It's one of the key things I think is important about it. It helps us be in the same shared mental framework. And it makes culture a practice, not just something we talk about, but something we're actually trying to do. Next slide, please. So for me, the future of safety culture through simulation really is about simulation. We have to think about it expansively. At the moment, we treat it as an add-on to what we do, but I think the future is it is integrated into everything we do. It is a tool for the workforce to come in as change agents and say, this isn't working, let's simulate for change. And that's how we have to start thinking about it. And that's where we draw in. We don't add on to the quality improvement departments. We don't add on to these other departments. We draw them in as experts, and we design as experts of simulationists with their support and help. But we need to put ourselves centrally because this is a very powerful tool that's not being treated that way. We need to be co-designing with patients. We need to be using the theories and the stories to design our simulations. And we need to share work globally so that we can really come together. And I'm going to finish up really and say that culture eats strategy for breakfast, but transformative simulation is a framework that really shows us the way, shows us how we can create culture safely. Thank you. I hear you. Oh, is it just me?
No, no, we are not able to hear you. No, if you can activate your mic, please.
Oh, sorry. Thank you, Professor Weldon, for this presentation. Now we have 8 minutes for questions. Professor Matos, feel free to answer the previous questions are on the Q&A session. So is there any questions for Sharon? I can start by one question. Is what are the first practical steps institutions can take to foster a stronger safety culture?
Oh my gosh, again, like Francisco said, a big question there. I mean, I'm going to take it from the perspective of simulation, and we're seeing some of this already, but there's some examples around the world in healthcare organizations where they are taking simulation. And there's one, for example, in Scotland where they've taken transformative simulation at a governance and leadership level. So they have implemented it in as part of the wider system. And with that, what they're managing to do is, as problems, and Francisco said this as well about project-based, as problems crop up, they're able to be responsive to it with simulation, drawing on all the different departments and approaches and using it more structurally in that sense. And they're saying that actually it doesn't cost a lot. We keep saying simulation is expensive and time resource, but they're finding it's not actually that expensive, really interestingly, but it's having huge impact. They had examples that were massive, like they had 165-year waiting time for small equipment, which was causing huge safety problems to patients who were going home and not able to have the equipment they needed to, function. And they got it from trying to solve it for a decade, this problem, and they got it from 165 years to 0 just by using transformative simulation approaches, trying to make change collectively. And there's huge amounts of examples of this happening. And when you think about that, and so that is a real culture shift, because it comes from the leadership enabling the staff, but through a kind of system and framework. So there's lots of things we can do, but I think, bringing people together in that way and enabling them is just fabulous.
Thank you, Sharon. And what about, how can simulation address not only to technical errors, but also cultural barriers?
Well, again, like I was just talking about in that presentation, I think it's about that shared purpose and understanding. And sometimes we don't understand why errors are happening, because there's some glitch along the way that we just can't see ourselves from our position and our lens. And using simulation allows us to see those different perspectives, but the same from culturally as well. I mean, it really, for me, doesn't matter. Culture, as I said right at the beginning, is different per country, within countries, everywhere. We're all part of multiple cultures, and we can create cultures when we want to. And that's what simulation does. It brings us into like this imagined shared environment where for a short period of time, we all generate a culture, a purpose, a togetherness. And it's just magical. We play, essentially.
Yes, thank you very much. Is there any other questions? I'm looking. I think it was clear, and I think you said two words very important. It's that the team working. I think it's very important, and all the interprofessional stuff, because we cannot evaluate, and the big challenge you said, you and Francisco, is to accept the changement, the move, and to change our minds and our mindsets to improve patient safety. So I think we are already closing the session. So
no, sorry, please. Maybe we have a small question from Danish Islam. If you can just check the Q&A box. A question from Danish Islam. Just activate your mic once again, please. Go ahead.
Okay. Is there a control within simulations we can use to see the validity of results?
I mean, there is when we're talking about simulation more broadly, but I think that's where we've been coming unstuck with simulation, quite frankly. We've tried to take a biomedical model of, approach to validity and research and stuff and put it across the simulation. And actually, there's certain things we can simulate exactly every time, particularly technical skills and things like that, we can kind of get right. But the reality is now simulation is being done in more complex ways. And every time we do it, just like in healthcare, it's never going to be the same every time. And we don't want to create the sameness every time. Sometimes we do, like with technicals and this stuff. But when we're talking about culture, we're talking about teams, organizations, those things, you don't want to replicate everything to be perfect every time. It would never be able to, and it can't. So looking at things like validity, we can look, if we try and create simulations that have validity, there's a usefulness to a point, but there becomes a point where it actually starts stagnating and doesn't allow us to change in a fast changing world. And that is the issue. We have to move away from that model a little bit. And it's very complex because, like I said, again, simulation's so complex. It depends what we're looking at here and the lens we are. But if we're talking about transformative simulation, validity is not useful in that sense.
Thank you, Sharon. Is there any other questions? No? So thank you very much. I would like to thank Professor Weldon and Professor Matters for your insightful presentation. This session has highlighted how building a strong safety culture and embracing system thinking can transform healthcare for the better. So and now I hand over the moderation to my friend and colleague, Dr. Miriam Alami, who will close and chair the next session.
Well, thank you, Professor Kawi. Thank you, Professor Sharon Mary Weldon and Professor Francisco Mayomatos for this inspiring start. We will now take a 10 minutes break. We will be back at 10:20 with session 2, Simulation Integration and Impact, shared by my dear friend, Professor Yamama Ammar.
Thank you.
Morning, Pierre-Luigi. Can you hear me, please? Pierre?
Yes, can I hear you, Mohammed? Good morning.
Morning, my dear. How are you doing?
I'm very well, thank you very much. What about you?
I'm doing very good. So finally, you will be able to do it live?
Yes, I succeed to do that. I changed my plan because I
Yeah.
wanted to be live with all of you.
And it will be amazing. Thank you very much, Pierre-Luigi.
Is
for
it
being-
working?
Yeah, very
Okay.
nice. No problem. Full
Okay.
speed. Everything is going well. Okay.
Okay, so I stop the presentation and wait for the end of the break.
Thank you very much. Bye-bye.
Bye. And good morning, Professor Mayamama.
Good morning, Professor.
Hi, Pierre.
So welcome back, everyone. We will continue with our second session. Our next chair is Professor Yamama Ammar, Professor of Nephrology in Rabat and member of the Moroccan SIM Board. She has been instrumental in the development of simulation in medical education. Professor Ammar, please take us into session 2.
Thank you, Miriam, for your kind introduction. Good morning, everyone. Welcome to the second session of our International EVE Conference. The session I'm honored to chair today will cover the integration of simulation and its impacts. In order to discuss both items, we have 3 experts who will share with us their knowledge and, more importantly, their best practice. Let me remind you that each speaker has 20 minutes for their presentation, followed by 10 minutes for questions and discussion. Before giving the floor to our first speaker, Professor Ingrazia Pierluigi from Italy, I will try to summarize his rich biography in some words. Professor Pierluigi Ingrazia, welcome. He's a specialist in anesthesia and intensive care and has a PhD in disaster education. Professor Ingrazia is the scientific director of Centro di Simulation at Centro Professionale Socio-Sanitario in Lugano, Switzerland. He is the current president of CESAM, the European Society of Simulation, and past president of the Italian Society of Medical Simulation. He is founder of the Simedita publishing house, as well as editor-in-chief of SimZin, the simulation magazine. Today, Professor Ingrazia will share with us his experience in institutionalizing simulation in hospitals, from pilot to policy. We are all ears, Professor Ingrazia. The floor is yours.
Good morning, everyone. Good morning, Professor Yamama. I would like, and good morning to the distinguished guest, to the academic colleagues and to all friends. On personal basis and on behalf of the Society for Simulation in Europe, which I also represent, I would like to thank all the organizing committee, Professor Moawi, and also Dr. Alami for the kind invitation. I'm very proud to be here with you for the second year in a row. So thank you very much for the continuous trust. I'll try to share my screen. So if you please can give me feedback whether it's correctly shared. I think it might be on screen correctly. If something's wrong, please let me know. So the topic that I was invited to talk about is, in my opinion, very, very important. Very important because I consider it as a key in the success of of the use of simulation as a real patient safety tool. So we are now, so how to institutionalize simulation in hospital or in any healthcare system. Let me first share my conflict of interests. I think Professor Yamama already reported in brief which is my role which are my role in the simulation community. I'm very fully involved either at the professional level, leading a simulation center, but also at the scientific level, publishing articles and writing books, and also being myself a publisher, but also at the association level. And I'm, as I said, I'm the current president of the Society for Simulation Europe. So this is also, I have some sort of collaboration, especially at the Italian level, with some industries. And, beside the last one, probably the ones that I reported at the beginning are not the real conflict of interest, but I like to disclaim that I am a simulation enthusiast. And I always do that at the beginning of my presentation because, I don't know whether it is a bias or could be a bias in the way I'm going to let's say, talk about what I'm going to do. So please consider my enthusiasm as a possible bias, but to prevent my enthusiasm myself, I used to, and I want to report some science. So I think this is going to contain my enthusiasm and will make my presentation more solid. So I decide to talk about institutionalization of simulation in hospital, dividing the talk in 4 different elements. So I'd like to identify, first of all, the context where we live and where we work, especially, and then I try to understand together, share together my thoughts about why we have to institutionalize simulation and how we can do that. Based on literature, and I would like to report an example, a concrete example, personal examples, what we are doing in my environment. So the context first. So I think we are all aware that healthcare organizations worldwide are facing with changing needs, from patients, workforce, new technology, or regulation. And I would just want to report some cases or some facets of these challenges. I think we are aware again that healthcare workers are in a very difficult situation. A perspective article from the New England Journal of Medicine a couple of years ago already reported how the situation was bad before the COVID, and after the COVID is even worse, considering or reporting that almost half of the workforce worldwide are suffering some sort of mental health disease, spanning from burnout to depression, insomnia, even until the post-traumatic stress disorder. And I mean, the figures are reported from different professional organizations and in different scientific journals. The workforce, it's low in terms of number year by year. And in 2023, The Lancet published an article, if I well remember, based on the International Labour Organization. So based on the statistic of the International Labour Organization about the workforce in active position until 2019. And the report stated that we are globally facing a shortage of almost 6 million of physicians, around 30 million of nurses, around 3 million of dentists, and 3 million, just less than 3 million of pharmacists. And I mean, this is a global challenge which no country is, let's say, is immune. Technology is something that it's transforming the future of our healthcare. We are already overwhelmed about technology in our world. But a new concept is emerging right now. It's called the digital clinical safety, which can be, let's say, divided in two components or analyzed in two components. One is the intrinsic safety of innovation. So the fact that the innovation, the technology doesn't make any harm. And the second is the extrinsic safety. And this means the way the clinicians are using the innovation and not causing any harm. Also, I mean, we are facing a situation where we as a caregiver are less and less exposed to, I mean, different situations, and sometimes less forced to perform treatment and procedures due to the advance of the preventive medicine. And this is causing a degradation of our skills. So there are, again, studies that are demonstrating this situation worldwide. And then, I mean, training and keeping of qualified healthcare workforce is becoming also a challenge. So many systems are not able to allocate the right amount of resources to maintain this workforce, either up to date, skilled enough, and due to training and maintenance of competence. And in this context, simulation emerged. And some authors, some colleagues are now considering the simulation the real new modern paradigm shift in healthcare. And I don't go into details of what simulation is, because we are all very knowledgeable about what it is. So, but this is the context. This is where we work, and this is where we would like to institutionalizing simulation in hospital. So, and my first question is why? So why we have to institutionalize simulation? Why we make simulation, let's say, mandatory and integrated in the system? And I would like to answer this question, reporting science, reporting literature. And I will start from, from the very, let's say, from the bottom of the strata of evidence scale. So sharing the, what came from the consensus of experts up to the, systematic reviews and meta-analysis. So the literature is now full, I guess, of evidence that simulation works. We are still looking for more, but I mean, we can be pretty satisfied about what the literature says about the effectiveness. And I just would like to report and share with you, I think we all know the global consensus statement on simulation-based practice. It's an international, a global declaration, generated by representatives from 50 societies. I know the slides are probably not readable, but I just wanted to report all the society which actually contributed in this tremendous, impactful and meaningful document. So what is the value of this document? The value is that in the document, in the statement, this society, the experts agreed about the challenges, and I reported more or less are universal. But in the most important is they agreed about the fact that simulation is a tool to overcome those global healthcare challenges. And the effectiveness simulation goes beyond the let's say the effectiveness in training. Simulation can support improvement in patient experience, can reduce education inequities, can optimize process and systems, and enhance the safety culture. And I can go through the list, but the main concept is that simulation is not just a training tool; it's let's say managerial tool for risk manager and the healthcare managers to improve the quality of the care and the system itself. And again, the literature, I just would like to share what has been published in the New England Journal of Medicine recently in May. So it's a nationwide study which demonstrate how simulation-based training and quality improvement programs together can significantly reduce perinatal mortality in low-resource setting. So up to 18% of reduction in perinatal death was caused by the introduction of simulation-based training systematically. So it was institutionalized. And that's, I think, is tremendous. Honestly, I don't recall any other drug or any other intervention which probably have some effectiveness. And again, also there are many meta-analyses which demonstrate how simulation-based education significantly enhance competencies at any level. And I don't go into detail because otherwise we would take all the time available. But just would like to report also some other cases. For example, how simulation training based on critical situation exposure seems to have a positive and rapid effect on stress, anxiety, and burnout. So again, facing one of the challenges that we are now facing with. Or how simulation reduce how simulation-based team training served as a protective factor against sick leave. And this also is an important, let's say, tool that our managers and our director can use to reduce the absenteeism. Or again, how just in training, simulation training can improve learning and performance outcomes, in particular time to complete skills. So we can reduce the time to complete skills, and this will we will see also the healthcare system less expensive also for the patient. Or how, again, this white paper demonstrate or identify simulation as one of the main components to provide to increase safety in the use of new technologies. Or even how we can use simulation to foresee and test our facility construction of buildings before the buildings occur, saving money in the future. And this is an interesting case study which reported how simulation-based testing reduced or saved $90 million in one single case. And as I say, also, there is already evidence how simulation can have an impact on the direct cost of the care of the care provided, and also can have an impact in the cost of insurance for the patient themselves. So I think this is, in my opinion, explain why we have to institutionalize. So it's not because we are some enthusiastic people who are claiming for how helpful simulation is, because evidence is saying that we need it, we can use it for different purpose. So, and then my second, let's say, element of talk is how we can institutionalize. And then I think we are all aware that, I mean, I think we witnessed situation where, you know, small number of simulation enthusiasts in hospital, I mean, play or run simulation experiences, or but they are, let's say, of course, effective at the micro level, but not very effective at the macro level. So the literature demonstrates how initiative based on discretionary efforts of a few often fail due to the lack of support, resource from management, or proper integration into organization-wide system. So we need to actually carry out a organizational change. So what we have to aim as a simulationist, as healthcare provider, is to achieve an organizational change in our system. And again, the literature come and help us. And so there are many models how to integrate a change in a system. And I just want to report the Kotter model, which is, I think, a very simple. Please forgive me if the slides is full, but if you look at the right-hand side of the slides, there are 8 different steps that might be accomplished or carried out to make the change effective and integrated into the system. So if you go through all of these steps, we have it's very likely we are very likely to succeed in this change. And for example, I report this this study conducted by Schmutz, which is to institutionalize an interprofessional simulation education program. And he was able to, and I invite all of you to read it, because he identified factors that can ensure the successful implementation of HISEP and explore the potential effect on organizational process and culture. I think it's very interesting reading. And I mean, but then I would like to report which is my personal experience, one of my personal experience as a concrete example. So we took the Kotter model and we implemented in one of the hospital, my simulation center serve is the Bellinzona Hospital. It's a mid-size hospital, almost 13,000 beds patients a year, with almost more than 50,000 comings into in the ER, just to give an idea. And it employs around 3,500 caregivers and administrative and also ancillary personnel. So we made a joint collaboration. So we established a formal collaboration with our simulation center, and we implemented what we called the model Be Safe. So actually, we integrated the risk management and the insight of simulation in a very let's say, systematic way. And I'll try to report very briefly what we did. So first of all, we established a formal simulation group, which called the SIMPAS, Simulation for Patient Safety, composed by 3 main categories of experts. So the risk manager, the caregivers, so physicians, nurses, and whole healthcare professionals, the expert in education, and experts in simulations. So those 4 components compose the group, and we let's say applied a model which consider the threat, the risk, and the resilience, putting the simulation in situ simulation just in the middle. And let me explain. So how we select cases and situations. So this is a job carried out by risk managers, of course. So through their, dashboard, which analyze the near miss or adverse event, they come up with a list of possible events. Selection criteria were identified based on a type of probability of effect, impact, and so on. And so this helped the risk manager to select the cases which need to be analyzed by in situ simulation, and then the risk manager, let's say, provide or identify an annual plan of, let's say, simulation-based intervention needed. So once the plan is identified, we then identify the case. And to identify the case, what we do is a deeper analysis of context and process. So we come, and this is a job conducted by risk manager, and in this case, the clinicians. So they analyze the process, okay, all the entire process, and each single node, using so higher level mapping tools like this is one of the examples, the SciPoc, which analyze different components in a very easy way, so also understandable for a clinician like I am. And we identify, for example, in the process of this is an example, no, coloscopy with polypectomy, we consider just one single node, for example, the bleeding management. And once the bleeding management is identified as a node, so they identify the deviation, so the possible deviation that they can occur for the regular process. And then compose a sort of risk scenario map. So, and this map is delivered to us as simulation expert. And this is where we jump into the process together with the clinician, and we develop the scenario and conduct the artificial experience, the simulation. So the scenario is developed using the tools that the literature, provide, or about how to develop scenarios. And we run our, setup and our feasibility, first our feasibility analysis, and then the setup of the in situ simulation. We run the artificial experience, of course, and then we conduct, as usual, the debriefing, but using some specific debriefing technique, which better, or in our opinion, better apply to workforce in active service in situ, in clinical environment. And we provide a final report which identify specific error and problem in cases. So these are designed and agreed by all the team of all the debriefees. And then again, we go back to the risk managers together with the caregivers and the simulation experts, and we create what we call the resilience map. So for each of the errors or the elements which threaten the patient safety, we analyze the factor and barriers using the Vincent factor model, so which is able to identify six different elements in each of the barriers and factors. And this will provide at the very end a very intuitive map of the priorities for actions. So you can see here what appear in red means an immediate action needed. What appear in green means that it needs attention, it will be addressed, but we have time to do that. And I report which are the effect that we noticed after 4 years of intervention. So we noticed first an increase in terms of participation to these in situ simulation events. So the people who joined the in situ session increased year by year, but also what we noticed was an increase in some KPI of psychological system safety. In particular, the self-reported non-conformity. So people who reported spontaneously about non-compliance with the standard, and also the spontaneous reporting of near-miss event. So reflecting an increase in the safety culture of the system. And I mean, the numbers are evident. So we went from from a lower number to a very high number in the 4 years. So I took my time, and I hope to have shared with you why we have to institutionalize, how based on the literature, and I try to provide a concrete example of how this institutionalization of simulation really work and really have an impact. So I thank you all for the attention. I'm very happy to answer all questions, and let me conclude inviting, of course, all of you to our next annual meeting, which will take place in France in June next year. Thank you very much.
Thank you, Professor Ingrassia, for this didactic presentation. I would like to reassure you that we have all the conflict of interest of being simulation enthusiasts. Due of lack of time, we are running out of time. So if there is one question, or we can keep the questions at the end of the session. Okay, thank you, Professor Ingrassia. You can ask your questions, dear audience. You can ask your questions in the Q&A box, and Professor Ingrassia will be, if he is willing to stay with us until the end of the session.
Sure,
Thank
my
you.
pleasure.
Alors, it's time to welcome our second speaker, Professor Mohamed Anas Fadi, who is an anesthesiologist and intensivist in the Trauma Center of the University Hospital Ibn Rushd in Casablanca. He is an active member of the Morocco SIM, and he's a passionate and expert teacher by simulation. Professor Fadi will share with us his thoughts about the curriculum mapping for simulation by answering two key questions: where and why. The floor is yours, Anas.
Thank you very much, dear friend Yamama. Thank you to the Morocco SIM board for inviting me to this conference. And it is a great honor for me to be a part of this honorable conference years and speakers to speak about a subject that is very important in simulation and in patient safety. I will share my screen to show you the presentation. And just to say, I stumbled upon a question in the chat room. It is a very good question that will make it easier for me to introduce this subject. The question of Iman about how to ensure that simulation will be working as a way of teaching. The presentations before me made it clear that simulation works as a way of teaching, as a way of training. It is an effective way, of course. How can we make it work? How can we use it? It is through a curriculum. And when we talk about curriculum, it is the integration of simulation in a curriculum that is the most hard to do. And that's what we'll be seeing in this presentation. Before getting to the mapping part, we will have to answer some questions first. And those questions are the questions of my dean, Gargamel. He's a dean of a faculty. It was difficult to convince him of simulation as a teaching tool. Now that he is convinced, it is way harder to convince him to change the actual programs of the faculty, to change the curricula that are already existing to implementation as a way of teaching in these curricula. My job to convince him through these presentations. All pay attention. So, it's an effective tool for teaching or just a fancy way to have fun? With all these mannequins, these technologies, computer-based simulations, these virtual reality platforms, is it just a way to have fun or to teach effectively? Well, as it was shown and proved via this morning's presentations, it is a way to enhance skill acquisition. There is no better way to teach what knowledge, to teach skills and attitudes for students than simulation course associated with other medias of teaching. It is enhance the patient safety via the error reduction and the enhancement of clinical outcomes. Also, it gives a safe and repeatable learning for the students so they can, through the deliberate practice, do unlimited repetition, the mastery of the skill that we want to teach them. Also, the environment is safe through good judgment and through less stress than real life. With the immediate feedback and assessment through the debriefing at the end of each teaching modality, we assure that the messages are well given to the students. And as Pierluigi said, there is a strong evidence base about how simulation works, and he has shown you all the studies that proves that. Next question about curriculum mapping. Is it a sophisticated bluff or a vital concept to adopt for each teaching activity? Do we have to do this curriculum mapping? Do we have to integrate simulation in a curriculum, or we can just do it as an isolated activity? Let us first define what is a curriculum. To do that, when you look in the existing bibliography, in the existing papers about curriculum mapping, about curriculums in simulation in healthcare, you will find a lot of definitions. I will show you 3 definitions that I find interesting to understand the curriculum concept. First, it is an attempt to communicate the essential principles and features of an educational proposal in such a form that will allow us to criticize in a scrutiny and to translate into practice in an effective way. So it is about the principles and the features of the educational experience. It is also defined as a planned educational experience. This planned educational experience can be one session about a specific subject or multiple sessions. It can also be a year-long course or just a clinical rotation or an entire training program. So a curriculum can be used for an activity or one session, and it also can be used for the whole training program of the desired faculty. Lastly, Dylan Shear proposed this definition. So he says that a curriculum is a set of planned actions designed to foster learning. It includes defining teaching objectives, defining the content, defining the methods, including assessments, also defining the materials, including textbooks, not just simulation, and also defining the provisions necessary for the appropriate training of teachers. So we can see that a curriculum is far way than just a program. And we should highlight the confusion that can happen between the program concept or the curriculum concept. And it is a confusion that came from the shift away from the old ways of learning that were subject-centered to the new ways of learning that are student or trainee-centered. So the curriculum will place a greater emphasis on the processes and needs rather than the content. The program in its way will be just dealing with the content. The curriculum will also enrich the notion of teaching program by specifying all the key variables of the educational and training process itself, from the pedagogical methods to modes of assessment and the management of learning. So a curriculum can be for a specific course or sequence inside the program, but the program will be the whole qualification or course of study. The curriculum will have to specify the competencies, objectives, content, the teaching methods, the assessment tools, and the schedule for that domain. Also, the program, on the other hand, can house multiple curricula. So why the curriculum mapping? Because nowadays we are using a student-centered competency-based approach that will have to deal with three major components: the cognitive, which is about knowledge, the psychomotor, which is about the skills, and the affective, which is about the attitudes. And the best way to teach all these three components for a student is through simulation associated with other media of teaching and training. That's why we'll have to do the curriculum mapping. But first, should we implement simulation in a new or existing training curricula or use simulation in a separate way? Is this implementation will enhance the training outcomes, or using simulation as a separate activity can do the job? Multiple papers discussed these questions. We will see the systematic review and meta-analysis by David Cook that treated about 600 articles to answer two questions. Is simulation effective versus no simulation at all? The second question is the different instructional designs that are used, do they have any impact on training or patient outcomes? The first question is, does curriculum integration enhance knowledge or skills retention if simulation is integrated in a curriculum or used separately? It was proved that when we use simulation in a curriculum, we will enhance the knowledge and skill retention. So don't run simulation as an isolated activity in isolated workshops, but embed it within a curriculum. Second question is about, does curriculum integration enhance process skills and product skills? There was no positive difference between curricular integration or no curricular integration of simulation. So we should not expect integration alone to increase process and product effects. But on the other hand, we should focus on the content, on the educational objectives, and on the way we are doing this integration. And lastly, is curricular integration of simulation positive for patient outcomes? it has not been showed here that alone integration of simulation can enhance patient outcomes, but it should be paired with integration with spaced training, distributed multi-day training, and also the mastery-oriented design to enhance the patient metrics. Now that we know that curriculum mapping and curriculum integration works, how can we integrate simulation into the training curricula? Multiple frameworks were proposed through different papers. They have in common these steps. Firstly, and very vital step, it's the needs assessment. The needs assessment is essential to fix the learning objectives, and to answer these learning objectives, we will have to embed simulation in the curriculum in its right place through its right means. And lastly, we should assess, we should evaluate. In this paper, they proposed 11 criteria to use to integrate simulation in curriculum, and they emphasized on the importance of needs assessment to provide the foundational evidence of the need for a well-designed simulation-based experience. Once the needs assessment is done, we can fix the educational objectives through the Bloom's taxonomy, of course, and we can also use the SMART technique to have measurable and attainable objectives. This paper highlighted the importance of incorporating simulation into a curriculum by first determining where it will be best used, so that we can have an effective way of the modality of simulation, and that, of course, will go with the needs assessment. After the needs assessment, the simulation experience must be planned, scheduled, implemented, and lastly, evaluated in the context of broader medical curriculum. They highlighted also the importance of that simulation must be part of a standard curriculum for a more successful experience for the student. Also, the importance of determining which components of a curriculum can be enhanced using simulation-based education to a more goal-directed use of this tool. They proposed these 4 steps to implement simulation in a new or existing curricula, from planning to implementation, thirdly, evaluation, and lastly, to revise what has been done to have a constant way of improving this framework. The planning is the most important step in this framework, as well as all the framework that we'll be seeing, because planning should treat all these questions, from defining the curriculum and the outcomes, selecting the outcomes that can be enhanced and that are suited to simulation, choose the right simulation modality, pick a delivery mode for the exercise of simulation, which from facilitator-led small groups to peer-led to self-instruction, develop the content from cases to scenarios to skill lab activities, plan the logistics from scheduling to space and equipment, and very importantly, the faculty preparation. The people that will be realizing this curriculum must be prepared, must be trained also to use this tool as in an effective way. And lastly, designing a feedback approach and tools. After planning the implementation by running a simulation-based education sessions, with a pilot experience first on a small cohort to test the effectiveness, to see if there are things to be fixed before enlarging the use of this approach. Also to troubleshoot in real time to fix what can be fixed. The third step is to evaluate the learning outcomes from skills, from knowledge, attitudes, or clinical impact through the means of evaluation. Also, we can evaluate the learner satisfaction from the exercise, the facilitator, or the feedback quality, and the instructor satisfaction also about the process and the modality usability. Lastly, we should revise. We should improve what we had fixed as a curriculum by updating scenarios based on the evaluation and the new evidence through the results of the assessment, and iterate as needed, repeat as needed to have a continuous cycle of improvement. Of course, there are barriers to curriculum level simulation integration. From time, it needs a lot of time, a lot of from the faculty members to the students also to have to choose the right time between their courses and the hospital rotations. Also, it demands a lot of resources, human resources, logistics, leadership buy-in. It is important to have the backing up of the faculty member, also the scheduling pressure and the faculty capability about using the simulation as a tool of learning, of teaching. Second framework was proposed by Chiniara using this fourth level model from instructional medium, which are the media used to deliver the educational objectives, from textbooks to lectures to computer-based exercises to simulation as a medium also. Second level is the simulation modality, which can be computer-based simulation, simulated patient, simulated clinical immersion, or procedural simulation. The third level is the choice of the instructional method. It can be the self-instruction, self-directed learning, or instructor-based learning. And lastly, the presentation, which have to fix all the details of the simulation exercise, from the feedback, choice, fidelity, types of simulator, and we will see all these points. The first level is the choice of the instructional medium. It is the principal mode of delivery of instruction. It can be done through many ways, many types of media, from textbooks to lectures to simulation as a specific medium that can allow replicating reality and interactivity. And the decision of using simulation will depend on its acuity and opportunity. Acuity can be defined as the severity or the importance of the theme that can be used to be delivered through simulation. Opportunity is the opportunity for the student or for the learner to face this event in real life and to be part of its management. And through these two criteria, we will have what we call the zone of simulation. This matrix will allow us to choose when and for what objectives simulation can be used. We have four types of exercises, or four types of situations, depending on the acuity and the opportunity. First one is the high acuity, low opportunity. Now we talk about the critical events that can happen, but that happens very rarely. We can use the example in anesthesia of malignant hyperthermia. It is a mortal and very fatal condition when it happens in the OR. So there is a very low opportunity for the student to face it in real life and to learn it. And this kind of situations is the main core of the importance of using simulation. Also, the example of mass casualty incident in the emergency department. In high acuity also, we can have these situations of high acuity, high opportunity. They represent the situations that are very common, but that are very risky and very severe for patients, such as postpartum hemorrhage or hemorrhagic shock or cardiac arrest. This situation can be taught through simulation to assure a very effective teaching for the student so that we can improve its skills in managing this situation. The third type of situation that can be faced with this matrix is the low equity, low opportunity, which are the rare events with lower risk tasks, such as for example, the manual disinfection of a fecal mass. We can use simulation for this type of events also. The fourth and last type is low acuity, high opportunity, which represents the routine, lower risk activities. Simulation can be used for the technical skill aspects of these events. So now that we know which exercise and which events can be taught through simulation, we should use the adapted simulation modality. We should differentiate between simulation modality and simulator types. The question that we'll be asking ourselves in this level is how is simulation being used rather than which simulator must be used. The level 3 is the instructional method. Two types of instructional method can be programmed. Self-instruction, the learner can control the timing, the pace, and often the objectives. It can be used for procedural and screen-based simulation. The instructor-based learning needs an instructor's supervision and an active participation of the instructor from guided debriefing to active facilitation. The fourth level is about the presentation, where we have to fix all the characteristics that will define the simulation activity, from the simulator type to the scenario itself, to the type of fidelity, to the debriefing techniques and the debriefing types and the feedback techniques and the team that will be working on this simulation exercise. Once integrated, what should we do next? We have seen that before integrating simulation, we will do a needs assessment. After the needs assessment, we will have to fix the learning objectives. After the learning objectives, we will have to use a framework that will make it easier for us to implement the simulation. And at the end, of course, it is the assessment and evaluation. Each curriculum must have an evaluation plan, an assessment plan of the learner and of the simulation-based experience. This plan will be very beneficial for us as trainers to see what can be enhanced, what can be improved in our simulation exercise. We can use the fourth levels training of Kirkpatrick's from the first level reaction, learning, behavior, and impact. And the fifth and sixth levels has been added. It is about the return on investments that can be evaluated through the mortality rates or the effectiveness of our trainees in real life, and also the impact on society. The last part of my presentation will be to present our local experience with curriculum planning and curriculum implementation of simulation in our practice. First example is the program that we called Simulation for All. It was about implementing simulation for all levels of students of medical years, from first years to sixth years of medical studies. It was a step to implement simulation for two main aims. The first aim is to enhance and to promote simulation as a way of teaching, and also to show the faculty staff that we can do that. We can use simulation in as a curriculum in the program of each year of medical studies. So for first years, it was about anatomy through anatomy table, medical English through communication scenarios, and facilitating the stage, the clinical rotation. Second year was about the first secourism acts, the venous catheter and injections, also the anatomy simulation. Third year about punctions and tubing, semiology, and etc. So for each year we chose, we did a needs assessment to which parts can be enhanced through simulation, and we used the effective way to deliver that. The assessment of this exercise shows that a very big satisfaction in the learners. The other levels of evaluation are yet to be done. For this program, we for each activity we made a curriculum that fixed the trainers, the learners, the learning objectives, the simulator choice, the fidelity choice also, and the whole way of delivering the curriculum, so that each trainer will have to deliver the same objectives, and it will assure an effective way of learning for our students. Images from pictures from the curricula. Second, for interns, we did what we call in French interne tout terrain, or all-terrain interns, or it's like the mountain bikes. It's a way of implementing simulation in the teaching of interns that are freshly integrated in the hospital through many.
Anas, sorry, Anas,
yes.
we are running now on a tight schedule. Can you
Running out of
conclude,
time.
please?
Oh, yes. I will just do this in a quick way. Sorry. So for interns, many curricula has been used. First year residents of anesthesia and resuscitation care also we did a program for them that was formed from different curricula. And this is an example of our clinical rotations for fifth year students in our emergency department. It's the blue program, the red program for the sixth year students, and the blue and green program is for nurse students in our department. Our challenge actually is to update this program that is formed from different curricula for interns and residents in our department. As 1 year ago, we had a shift in our exercise with the operating room that was added in our trauma center. So now we will have to fix objectives for anesthesia for our residents, and we will have to do what we saw in this presentation, from needs assessment to objective learning definition, and etc. etc. I will finish with this 10 tips for a successful virtual simulation integration paper. It was done for virtual simulation, but I see that it is very beneficial to use these tips for simulation integration itself. So don't let the simulation drive the curriculum. It is the curriculum that should fix which simulation must be used. Use the right simulation in the right time for the right learner. Prepare the faculty and champions. Adopt learner-centered pedagogy. Use simulation for assessment also. And always very brief. The debriefing is a must, so it must be well done. Make the technology seamless. Collaborate widely and plan sustainability. At the end, mapping must be done before using simulation. Design for mastery and spacing exercise to enhance patient outcomes. Choose the right modality for the job. Debrief is the engine, so it must be done in a good way. And lastly, make it count. Thank you very much.
Thank you, Enes, for clarifying the place of integrating simulation in the curriculum, and for explaining exhaustively the steps needed to apply it. Due of lack of time, unfortunately, we will not be able to give the audience the opportunity to ask questions, but we will keep them in the QA boxes, in the QA box, and we will try to answer them in the end of the session. And it's time
Thank
to
you very much.
welcome Professor Adanés Martínez Gracia, who is the last speaker in this session. Professor Adanés Martínez Gracia is an emergency doctor at Al Birhan de la Arechaga University Hospital in Murcia, España. She is currently serves as Vice Dean for Clinical Simulation and Applied Technologies, and she is responsible of Integral Center of Clinical Simulation of Murcia University, and she is the president of the Spanish Society of Clinical Simulation and Patient Safety. Professor Gracia will address a topic in which he has recognized expertise, the performance assessment, particularly through OSCEs. Her presentation is titled Simulation as a Tool for Performance Assessment, Lessons from OSCEs. The floor is yours.
Thank you very much. Good morning. I would like to begin expressing my sincere gratitude to the Moroccan Society of Health Simulation for the opportunity to participate in this outstanding Congress. My special thanks to Mohamed Mohawi and Miriam Alami. It is truly an honor for me to represent CESEP. Thank you for the nice introduction. I have nothing more to add. I have no conflict of interest, just my love to simulation, as said Pierluigi. So we are going to start. In the next 20 minutes, I will focus on 3 key aspects. First, I will describe the structure and organization of the OSCE. Second, I will address the challenge this exam represents for students. And finally, we will explore the training tools that we have available to help students prepare for such a demanding exam. To begin, let us briefly revisit the history of the OSCE. The first OSCE was conducted in 1972 at the University of Dundee in Scotland. In 1911, following the adoption of the Bologna process, the Conference of Deans of Spanish Medical Schools determined that we need a structure stand capable of assessing not only knowledge but also a broad range of clinical competencies. These include story-taking, anamnesis, physical examination, communication, technical skill, clinical judgment, diagnosis and treatment, prevention and health promotion, interprofessional collaboration, and ethical legal aspect. After a preparatory period by 2015, all 40 medical schools in Spain carry out their first national OSCE exam. Each exam including 20 clinical stations or clinical situation. Then in 2020, the COVID-19 pandemic forced us to adapt. The OSCE had to be conducted in a virtual format. Since then, virtual clinical stations have become a permanent part of the Spanish OSCE system, replacing some of the 22 regulatory clinical stations. The OSCE in Spain is overseen by a coordinator elected within the National Conference of Deans and supported by a multidisciplinary committee. This ensures uniformity, objectivity, and rigor across all medical schools. The OSCE allows us to evaluate the third level of the Miller's pyramid, Xiaohou, that is the demonstration of clinical competencies. It can be defined as an objective and structured clinical assessment, an exam format that evaluates students' clinical skills in a reliable, uniform, and standardized way. It consists of multiple clinical situations called clinical stations that simulate real-life scenarios and situations. Today, it has become the final examination for medical graduates in Spanish universities. At the University of Murcia, we have around 220 medical students per year, which amounts to a total of 1,320 students across the 6 years of the degree. We conduct 3 skill-based exams in subjects of traumatology, medical surgical skills, and of course, the OSCE. With the OSCE, however, the focus goes beyond technical skills. It allows us to assess true clinical competencies in an integrated manner. Our local OSCE teams depends directly of the Dean's office. It is organized as a multidisciplinary committee, led by a coordinator and with individuals responsible for each rotation. In addition, a group of clinical professors rotate annually to contribute to the process. So, how do we organize ourselves? We begin each academic year with an inaugural session where we review the needs, contents, and competencies to be addressed. Work dynamics are explained to all members, and documentation and templates are distributed. In a second meeting, proposed cases are presented to the committee. Each case is carefully analyzed to ensure it is well structured, relevant, objective, and appropriate for the level of a newly graduate physicians. One policy, the checklist or rubric for each case, is reviewed and approved by a panel of experts. The teaching team responsible for that case meets to standardize actor performance. Finally, in our review sessions, we evaluate the balance of competencies across stations, resolve any doubts, and finalize the assessment. On the F of the OSCE, everything is set in place so that on Saturday morning we can begin what I like to call the final celebration of the medical degree. Each student progressed through 15 face-to-face stations with standardized patients or simulators. The exams is organized in 4 mirror circuits conducted across 4 shifts during the day. By the end of the day of the OSCE, 220 students around 16 evaluators and between 14 and 16 actors will have participated. At each medical station or clinical station, the student has 2 minutes to read the initial instructions and then 8 minutes to complete the task or solve the case. Evaluation is carried out using a checklist where the teacher marks the items performed correctly. When sufficiently trained, the actor may also evaluate the communication component. Results are delivered by competencies and then form part of the student's final grade. For students, however, this exam is a major challenge. It generates a high level of uncertainty and is often perceived with fear, since they are not used to this type of assessment. And if we want to align with quality standards, both ASPE and INALS remind us the importance of good assessment practices. One of their key recommendations is that students must know the rules of the game clearly before being evaluated. Training is therefore essential. At my university, we have a very powerful tool, the MAES methodology. MAES is the self-learning methodology in simulated environment. This method establishes baseline competencies, set learning objectives through collective brainstorming, and then designs a simulation scenario aimed at developing those competencies. Students participate in the simulated experience followed by a structured debriefing and a presentation of the competencies acquired. This methodology is implemented by the students themselves, and that is the importance of this methodology. This methodology is currently implemented in 14 European and Latin American universities and is supported by 19 scientific publications. So, let us put this methodology into practice. We decided to apply self-learning in simulated environments to the dreaded OSCE, and then evaluate its impact on both academic performance and students' anxiety levels. Participation in this program was entirely voluntary. Out of 201 students scheduled to make the OSCE. 122 enrolled in the MAES basic training, while 49 did not participate. The 152 students were divided into 2 independent groups of 76, with no communication between them. Each group was further divided into 8 subgroups of 10 students. They created a group identity, chose a name, and reflected on what each member contributed to the team, an initial exercise in collaborative learning. Students were provided with all the documentation required to begin their preparation. And for 2 weeks, the groups worked on OSCE cases under the guidance of professors involved in the exams. Each group then presented their 8 cases. A pilot run was conducted, followed by final correction and adjustment. The OSCE training using MAES was organized over 2 afternoons. On the first, Group 1 acted as evaluator while Group 2 performed the exam. On the second afternoon, the roles were reversed. This provides a valuable peer review component to the learning process. Afterwards, a debrief session was held to analyze the cases. Students received competency-based feedback and grading, reinforcing the collaborative learning experience. To evaluate the impact of this training, we compare the results of the final OSCE, the RIAN, between students who had participated in MAIS preparation and those who had not. The results show an statistically significant improvement in the grades of students who had undergone MAIS basic training. Although we are still in the process of measuring its influence on anxiety levels, feedback from students suggests that this methodology not only helps reduce stress, but is also perceived in a highly valuable and enjoyable learning experience. As you see, this is great, very useful, thanks a lot, constructive, you worth attempt, for example. In conclusion, it is essential for students to understand what competency-based assessment truly means. They must be familiar with the OSCE system and the methodology that underpins it. Proper training not only enhances their performance, but also provides them with the confidence they need to face an exam. And that is my experience that I share with you. Thank you very much.
Thank you. Thank you, Professor Adanez, for this insightful presentation where you explained the methodology of self-learning in simulated environments in the topic of assessment. So it's time for questions. Feel free to engage with our presenter and ask questions or share your thoughts. Is there any question? For the questions previously asked for the two first presentations, the speakers answered the questions in the chat. So please check the chat. For this presentation, have you any questions? Professor Adib, our expert in OSCEs, can you share with us your thoughts? I have a question in the chat. How long OSCE exam takes?
How long is 10 minutes about each clinical station? So we have 15 clinical stations, so it's almost 2 hours. It's 150 minutes, exactly. Because they have 2 minutes to rate the initial situation and then 8 minutes inside the clinical situation to solve it.
Okay, thank you for your answer.
But we repeat this in 4 shifts, so it's all the day long because we have 220 students.
Okay, and a question from Asma Al-Hababi. Do you integrate learning theories in teaching by simulation? I don't think it's for your presentation, but you can answer if you want. Carolina replied to your answer and said, 220 students per 2 days? Professor Garcia.
Sorry,
it's,
Carolina, reply to your answer.
220 students for 2 days?
No, in one day.
In one day.
Yes, we divide it in 4 sheets, and then we do the in a mirror way. They have 15 clinical station, and then repeat in a mirror way. So they are what we say wheels. So we have 4 wheels at the same time in a mirror way. So we always there are 4 students. They are taking the same clinical station. I mean, I can show you if I can share. Was. So here you can see, this is what we call a wheel. And then here we have 15 clinical station. So this is repeat for at the same times in 4 ways. So we have 4 shifts and 4 wheels each time. So we are all day long because we have in the first sheet is from 9 to 12, for example, in the morning. Then we have 16 students evaluating at the same times. Then they go out and they come another 16 and so on. It's well, a huge number of students, but we manage, yes.
Okay, thank you. Got it. Thank you for clarifying it once again. So I think there is no more question, and this concludes our session of simulation, integration, and impact. I want to express my sincere gratitude to our speakers for sharing their expertise with us today. A big thank you to our audience for your active participation and engagement. And I give the floor back to our conference chair, Dr. Alami Younsi Miriam.
Hi again, and thank you, Professor Gracia, for this outstanding presentation. We are even more excited to be visiting you in Murcia in December. And many thanks to Professor Pierluigi Igrazia, to Professor Mohamed Anas Fihdi for their very insightful presentation, and a special thanks as well to Professor Yamama Ammar for expertly chairing this session. Once again, today's discussion have highlighted how rich and rapidly evolving this field is. We will now take a 10 minutes break. We will be back at 12. We will return for session 3, Human Factors and Patient Safety, chaired by Professor Mariam Fortasi. Welcome back, everyone. And without further ado, let us continue with our third session. I'm very delighted to introduce Professor Mariam Fortassi, a professor of physical medicine and rehabilitation in Tangier, vice president of Morocco SIM, and a leader in medical education with a very strong commitment to advancing patient safety. With that, I hand it over to Professor Fortassi. Professor Fortassi, your microphone.
Yes, thank you, Mariam, for this nice introduction. And as you said, we now move into the third session of our patient safety webinar, following two insightful discussions. This session will focus on human factors, a crucial element in understanding and improving safety in healthcare. We are fortunate to welcome three distinguished experts in this session who will share their perspective and experience. Our first speaker is Professor Denis Oriot, who combines extensive clinical expertise with pioneering work in simulation-based education, trained in neurosciences, pediatrics, anesthesiology, and holding a PhD in bioethics. He has over 25 years of practice in pediatric intensive care and emergency medicine. Since his first engagement with simulation in 1989, he has led the ABS lab in Poitiers and advanced research on performance, stress, teamwork, and debriefing. He is co-author of the widely translated pocket book for simulation debriefing in healthcare, and he continues to shape the future of clinical debriefing and in situ simulation worldwide. Today, he will speak on neuroscience-based clinical debriefing of advanced events. The floor is yours, Professor Oriot.
Thank you very much, Mariam. I would like to share my slide. Can you tell me if it's okay? Can you see the slide? Yes? Okay. I would like to thank
it's very visible.
The organizing committee of the Morocco SIM, and especially Professor Mohamed Mouawi for his invitation to talk about this subject, neuroscience-based clinical debriefing after adverse event. I have no conflict of evidence of interest to disclose on this subject, except being a debriefing enthusiast as well. With this topic, we will make a 180-degree turn from the system-centered debriefing to a brain-centered debriefing. As you all know, simulation debriefing has been developed for more than 40 years now to improve learning in healthcare professionals and students. Clinical debriefing is more recent, from 15 to 20 years, with the aim of improvement of professional practices, made mainly with hot debrief just after the case or the day after. And it's often using plus delta debriefing, and the debriefer belongs to the team. Rarely it's a delayed debrief after videotaped cases, especially in crash room or delivery room. It's delayed from 1 week or so. And the debriefer is not a member of the team, but he has or she had observed the video. Very rarely, it happened to be a delayed debrief after reporting an adverse event, and the debriefer, of course, is not a member of the team and is not an observer as well. So, why neuroscience-based clinical debrief? As you know, in simulation debriefing, while using the debriefing with good judgment to investigate the intention of any action, the frame is partially known or forgotten, or it's a correct frame with intercurrent delay or interruption of actions. On the opposite, during a clinical debriefing, we found very often a correct frame associated with an incorrect result, leading to an intention action gap. And in this case, this is no longer a problem by exploring the intention. But the problem is understanding the reasons for this intention-action gap, which is defined as a discrepancy between our intentions or what we plan to achieve and our actual actions or what we ultimately do. And there are three main methods commonly used to explore intention-action gap during feedback after adverse event, usually carried out by the risk management team. Ishikawa fishbone diagram, 5W plus 1H approach, alarm approach. These three methods have the same aim, which Swiss cheese slices contain holes that shouldn't be there. That is searching for missing security barriers like checking. And they also note any disturbing agent, environmental stress, note any suboptimal organization, suboptimal procedures. But they don't explore what happened in the actor's head. Unfortunately, because this awareness could decrease guilt of the second victim and offer individual techniques to prevent errors and secure actions, and promote a culture of error instead of blame culture. To better understand what happened in human brain, we have to rely on Kahneman, presentation of the functioning of the brain. In 95% of the time, our brain uses automatic system compared to 5% of the time where we use an analytical and decision-making system, providing concentration. Very simply said, system one is automatic, energy-sparing, fast, routine, unconscious, multitasking, and system two is quite the opposite, analytical, energy-consuming, slow, adaptive, conscious, and single-tasking. Very important, the 80% of the errors occur in professionals who are experienced and using system one. So what are we looking for during the neuroscience-based clinical debrief? We are looking for dysfunction of the situation awareness process due to an alteration of the situation caused by perception, altered understanding, insufficient, and anticipation delayed. That can be caused by different things. Reduced alertness, using shifting for system one instead of using system two. Inattention, overconfidence, disruptive stressors, high workload, fatigue, sleep death, routine, altered emotional state, cognitive bias, inattentional blindness, heuristic, uncertainty reduction at low cost, leading to automatism. Altered communication, incomplete communication, not to everybody communicating, non-verbal communication, non-verbalization, no recap, no timeout, no call for help, leading to no shared awareness of the situation, and any type of inhibitions of action that we will talk later on. So I would like to show you some results of our experience in Poitiers. We practice clinical debriefing for 15 years now in University Hospital of Poitiers and the area, and the small hospitals in the same area, mainly in emergency department, EMS, and pediatric emergency medicine wards. But since 2024, we had a mission from the Regional Health Agency to promote debrief after adverse event and possibly in situ simulation as well. So from that date, we collected adverse events from plenty of wards, a great variety of wards, geriatry, emergency, ICU, oncology, obstetrics, pediatrics, OR, pharmacy, nursing home, etc., from the University Hospital and some hospitals and small hospitals around it. And we collected some who had agreed for a debriefing. 24 agreed for a debriefing in 18 months, and among them 18 were dealing with medication errors. And to our knowledge, we didn't see any publication of the use of neuroscience in clinical debriefing. Among these 18 cases of clinical debriefing for medication errors, stress disturbers were present in 10 cases, heuristic in 6 cases, uncertainty reduction at low cost in 3 cases, and internal inhibition in 5 cases. Let's have a look at those 4 factors. As you know, there would be no life if there was no stress. And during the first phase of the Yerkes-Dodson curve, epinephrine is the molecule and associated with cortisol in the second phase. There are plenty of stressors: interaction of task, time constraint, technical problem, environmental parameters, lack of equipment, and clinical condition deteriorating of the patient. And this can modify the behavior from flow, which is called good stress, to fight and flight during the redshift of the curve, and even freeze, paralyzing the provider after the amygdala hijack breakpoint. What are the consequences of stress? Impairment of decision-making process, leading to dropout by decreasing in concentration capacity, in decision-making ability, working memory, few alternatives considered, no reassessment performed, tunnel effects, rejection of opposite advices or recommendation, and a massive regression of speech. This is due to the occurrence of the amygdala hijack of the prefrontal cortex, described by Coleman as sensory effect. Sensory afference reach the thalamus, and then to the amygdala some millisecond prior to the cortex, and checking with the hippocampus if there is any previous experience. And if so, they trigger a massive hypothalamus adrenal axis activation, leading to change in behavior, fight or flight, or even freeze reaction. And this is the hijacking of prefrontal cortex. So, next one. Most of you know this video called Romantic Dinner. Even you laughed probably after viewing it. What is it? It's a heuristic. What is a heuristic? It's a shortcut, hasty, approximate apprehension of the reality. It's meant to go faster, to take the right decision. But let's see some examples picked up from medication errors debriefing. One, imagine you are a medical student. You have 2 patients to vaccinate against COVID. Go get the vaccines in the fridge. You see 2 boxes with the Pfizer logo. You grab them. Unfortunately, it's not vaccine, but filgrastim. By associating the logo of Pfizer with vaccine, the medical student assumed he was handling the right medication by vaccinating the patient with filgrastim. 2. The nurse asked the student nurse, "Can you administer Atovaquone to this patient?" And she previously filled up the syringe with the medication. And the student nurse, seeing the syringe, administered the medication IV, assuming being in a syringe means to be injected IV. Of course, it's not IV, but PO, and the nurse had put the medication into the syringe because the spoon was lacking into the box. Next, you might know this paradigmatic flight accident of United Airlines 173 that happened 3 days after Christmas in 1978, when the plane was trying to land in Portland. The pilot controls both landing gears, only one light comes on. Operation is repeated by the co-pilot several times, the same result occurs. So there is a doubt. Is it a faulty indicator light and the train is out, or faulty control and the train is not out, which lasts minutes and minutes until the lack of fuel. So the descent of the plane occurs thinking that it was a faulty indicator. This is an arbitrary choice, leading to a plane crash with, unfortunately, 11 persons dead, 21 injured, and 179 survivors. They should have gone around and requested a visual check from the control tower, but this action demands more energy. Interestingly, flight to UA173 is a paradigm of crew resource management, cockpit resource management, leading to CRM principles the year after. There are several examples of uncertainty reduction at low cost. Let's show one. A young nurse taking care of a 2-month-old boy with a UTI, for which it was prescribed temocillin, 90 milligram IV. Medication was put in the fridge by a colleague the previous day, but the nurse doesn't know temocillin and doesn't know it's in the fridge. She looks in the medicine cupboard where are the nominative treatments. All have a sticker with the patient's name, except one, tobramycin. The nurse doesn't know tobramycin either. She said during the debriefing, by deduction, it could only be that one, ignoring the one in the fridge. I checked Google for the presentation of temocillin and tobramycin boxes. But for me, it was this medication, meaning tobramycin, and injected tobramycin instead of temocillin, leading to renal failure. So what you see, these 3 types of error that are not linked to a lack of plain Swiss cheese slices belong to a survival system. Written in our genes, when wild animals were all around the earth, more than 50,000 years ago. Besides this survival system, our culture brought some inhibition behaviors. Internal inhibition, Milgram effect, hierarchical inhibition, Janus effect, bandwagon effect, group effect, spectator effect, failure to invest due to the dilution of responsibility to act. If others do nothing, I do nothing. And external inhibition by peers, supervisors, patient, family, observers, lay people, etc. That can lead to the absence of action. So at the end of a clinical debriefing, what can we propose as areas of improvement? As for any feedback after adverse event, to get more staff, to have a better organization, better procedures, better communication, check the prescription before administering any medication according to the 6 R's, right patient, medicine, route of administration, dose, interval, and traceability. But what can we propose on the top of that? Interestingly, some of the 6 techniques for securing professional practices that have been proven with neuroscience. 1, pre-intervention, anticipation, which risk, this is a pre-job briefing. 4, during the intervention, use of aids, call for help checklist, cognitive aid, and so on. We'll talk of Chief Akenko later on. Times out, pause during critical actions, calculation, and so on. Reassessment with the CAP, leading to a shared vigilance. Secure communication, closed-loop communication, assertiveness, we'll talk. that in few minutes. Shared information. Secure actions, sanctuarization of certain actions perceived as critical with scratch check before action. Reset to 0 if we feel we have been interrupted. And one post-intervention hot debrief using a plus delta method. Let's talk about two of them, Shisa-Kanko and assertiveness. Shisa-Kanko, also called pointing and calling, has been discovered by Japanese at the end of the 19th century and is widely used in Japan in all industries since 1970s. It represents a potent activation of the prefrontal area by a neuroscience triangulation, collecting signals from visual, auditory, and praxic inputs and forcing the brain to use the system 2, leading to focusing concentration. It helps to stay focused on the task and has been associated with a decrease in errors by 85%. It has been also used by different medical associations, published last May, teaching pointing and calling, Shisa-Kanko, to reduce error and improve performance. What is assertiveness? It's a quality of being confident and not frightened, to say what you want to believe or believe, to counteract any inhibition, passivity. Being assertive means communicating with others in a direct and honest manner without any offense. Being able to raise the alarm, express concerns when something is going wrong, with different methods. Oscar method is one of them. It has been reported that structure assertive communication training with interactive exercise like in simulation enhance nurses' ability to speak up for medical errors. So in conclusion, speak up for safety. The two neuroscientific messages that can be given during a clinical debriefing to patient to prevent medication error are: 1, speak up to yourself by using Shisa-Kanko and try to understand what it is. And if you want to see exactly what it is, you can go to Netflix and see the bullet train explosion. You have a good example of what it is. 2, speak up to others by using assertiveness, especially in case of disagreement with others, to prevent, to avoid passivity and go from a passive behavior to an assertive behavior. Thank you for your attention.
Thank you very much, Professor Oyo, for this very insightful presentation. Very interesting to dwell into the neuroscientific basis of all of what happened during the simulation session and debriefing. While waiting for questions to start coming, I have a question myself. I'm quite curious, like when you do the clinical debriefing in your personal experience, do you go with the participants in the simulation experience itself during debriefing? Do you go through the metacognition discussion, like do you make them aware of which system of thinking was used in order to that led to the error, for example? Because usually when we debrief, we just focus on what happened, what was not done well, and how to avoid that. But do we push the participants to think about their thinking and why the whatever error happened at the first place?
Thank you for the question, Mariam. Yes, we go through the explanation of neuroscientific mechanism, and we found that it was a good way to decrease anxiety, decrease the feeling of guilt. And because in the introduction of this debriefing, we make an explanation of what is error, that everybody commits error. I commit error, everybody does. And error is physiology. Our brain is made with this possibility. And so the explanation, the precise explanation of the mechanism of error is something that can help the provider to understand that it's not something to be blamed for. It's something that is physiologic. And what is interesting is in which circumstances it occurred and what can we do to prevent recurrence of it.
Okay, thank you. So during this debriefing, I reckon that there will be some emotional expression, as you said, the feeling of the patient feeling guilty and trying to understand why this happened in the first place. So one of the questions we just received is that how do you balance the emotional regulation of participants and their cognitive awareness during the process?
The emotional part, the feeling, which is the reaction of the providers during the debriefing, is very, very important. It takes a lot of time to express for them what they feel. And I should say that some debriefing are made more than 2 weeks, 3 weeks, sometimes 2 months, 3 months after the event. Why? Because the provider is off work, because of a feeling of guilt and depression, and on medication, antidepressive drugs. And this is very, very important to notice and to have a psychological approach to this feeling of guilt. And so it's very, very important to take time to consider the fragility of the providers at that point. And the explanation of the neuroscientific mechanism is one way to recover from this, I would say, stress, post-traumatic stress for the second victim.
Oh, yes, thank you. So don't you think, or don't you agree that all the simulation educators should be trained to incorporate this kind of neuroscientific basis in their debriefings? It would make the debriefings even more useful.
I am thinking of it. I thought of it previously, but I'm not sure of that, because what I see is the debriefing during simulation doesn't cover the same scope as the debriefing after clinical experience. And so it's not the same type of errors, and it's not the same time and not the same way to investigate the occurrence of errors. And so I would say the neuroscience approach, I can see it's efficient in the clinical debriefing. I'm not sure it would be as efficient in the simulation debriefing. But it's a question.
Yes, thank you. I can see that. Yeah, sure. And especially that, yes, we need to train the clinicians to use the clinical debriefing after real events in real life, which is not so common so far. There is another question about the use of artificial intelligence, like if it could be used to configure automated debriefing system, and if it could incorporate the neuroscience into the into the artificial intelligence program. What do you think about that? Well, before I'll let you answer that and have your perspective on it, I just invite the participant, Armando Romanos, to stay with us until the end, because there is a specific session in this webinar about artificial intelligence coming just after. To you, Professor Oyo, what do you think? What's your perspective on the matter?
So far, you see, you can imagine it's a very private debriefing with a lot of feelings, with a lot of emotions, with a lot of sometimes tears. And I'm not sure the machine so far could handle that properly. Handle a handkerchief, give a glass of water, put a hand on the shoulder, comfort provider to go on to debrief. You see, I just show you some medication errors that were well handled and with few consequences. I didn't show any of the hard medication error, but they are with death of a patient. And so I we made debriefing as well. And this is quite difficult to handle. And this is a very strong time for everybody and the debriefer as well. And I'm not sure AI could handle this right now.
Yeah, I totally agree, and thank God that we still have this human touch possible, that AI is not competitive to human beings on this ground. Thank you very much again, Professor Oyo, for your very interesting presentation and sharing your expertise with us. And now, without further ado, we'd like to welcome our second speaker, Dr. Philomene Uwimana, who is a senior lecturer and deputy dean at the University of Rwanda School of Nursing and Midwifery, a nurse educator and leader. She has directed the Simulation and Clinical Skills Center and serves on national and international committees, including Sigma Theta Tau International. Her work focuses on maternal, newborn, and child health, as well as advancing interprofessional and simulation-based education. She will speak on how simulation can enhance interprofessional collaboration. Welcome, Dr. Philomene, and the floor is yours.
Thank you so much, Mariam. Good afternoon, everyone, and maybe those good morning. I'm really honored and humbled to talk after the other experts, like the professors who just shared with us that their expertise in terms of the previous on the debriefing and the other and the talk that we had since this morning. So as you said, I'm going to talk on the simulation to improve interprofessional collaboration. Maybe I start, a second, please. Thank you. During the first session, Professor Francis.
Uwimana?
Yes, please.
I wonder if you can activate your camera, please, for us.
Mine?
Yeah, the camera, but the mic is okay. We can hear you.
You can hear me.
But we don't have any video. So it's comfortable for our audiovisual system if... Oh, okay, it's coming.
Can you see me?
Yeah, very nice. Okay, you have to continue. Thank you.
Thank you. Yes, I was saying that since morning we were talking about the complexity of healthcare nowadays, and this requires effort from the diverse health professionals. And when we talk about effort from some people, they need to bring in their different expertise to contribute to the care of the client. So and this, maybe before I talk about interprofessional collaboration, I also want to highlight that previous to collaborate, work collaboratively, we have to have some competencies that would support us to collaborate with us on healthcare delivery. So that's why I wanted to talk about interprofessional education, which of course defined as a collaborative learning approach where different learners from different healthcare disciplines, they are engaged, they share the education experience, and of course learn to work together as a team, the community, and communication, I want to say, as well as the patient-centered care. So this will lead definitely to graduate interprofessional professional who should work collaboratively. And as it has been again said from this morning, simulation is one of the strategy that was thought to be the most one of the most strategies to train healthcare professionals as teams, with the ultimate goal, of course, to strengthen the teamwork for a better health care outcome. Next, please. So as we talk about collaborative practice or interprofessional collaboration, I was talking about, of course, different competencies that the professionals have to have. And this is about having competency with regards to interprofessional communication. I mentioned the patient-centered, but also when people are working together, it's important to have to know the scope of each professional. That means the clarification of the role in the team, as well as to have the team functioning. The team should have leadership, collaborative leadership competencies. And when it comes to some misunderstanding or some conflict on a team, these are the competencies that the professional should have. And it can be learned, and it is learned. Evidence have showed that simulation creates a safe, a structured, a controlled environment that enhances collaboration or collaborative practice. Why is it? Again, because it's a simulation. It can simulate the real world clinical setting, but it provides a risk-free where practice opportunities can be explored or are explored, and it supports trial and error learning, which most of the time it's not feasible on a bedside or in a ideal situation with actual patient, human being. Again, we just learned about debriefing. So while having this simulation session on teamwork, it's also encourage reflection, feedback on teamwork, and the enhancing communication. Again, when it is set as a scenario that reflects or mirror real world healthcare. So I would say that this is a thing that has been explored by different researchers, studies that shown that a simulation is a really a conducive environment where professionals can learn to collaborate or to enhance the collaborative practice. Next, please. Of course, I was talking about real world clinical practice that can be simulated with case scenarios, or it even cover can cover acute emergence, chronic disease, chronic conditions, even depending on how the scenario was set, you would have a dilemma, ethical dilemma to work collaboratively and try to work together to solve these issues. So simulation environment is a safe, as I would say, environment, a learning environment where health professionals can repeat and they exercise and they have feedback from others to enhance the competencies, as I have mentioned before. So again, I'll say, like, the studies that worked on this topic or this field of using simulation as a tool or as a strategy to enhance interprofessional team. They have highlighted that there is a closeness to the real world, as I have been saying. So then whether you simulate an emergency or an ethical issue, this one has been documented on that. Again, please go ahead, the next. Thank you. I would say to just emphasize on it, it's about learning, experiential learning experience. I mean, experiential learning, as we talk about in an environment, a safe, controlled, and structured learning environment, learners are in a situation where they can learn, engage, and reflect on their learning. So it's not a passive or just to receive information, maybe as it is in the classrooms or even when they are on bedside, where the preceptor or the mentor is talking, but in the simulation there's this engagement from the learners. They also have the opportunity to deepen the learning through experiencing teamwork challenges. Of course, one of the competencies I have mentioned before is about team functioning and conflict that can raise within the teamwork, like who is taking the lead and who is supporting, how is it coordinated? Is everyone getting the role of the other professionals? If the nurse, let's say in the case of a critical or emergency situation where we really have to have a good coordination of the team. So this is a situation when it is in a simulation where if something went wrong or the coordination it is not good, there would be this feedback, as we said. If there's a challenge that's raised, then they can learn from the experience of working together and get challenged in how to get through it. The other thing, it's about problem solving and the adaptability. And again, this is a competence that is really required as in a collaboration practice. And it is learned mostly in the simulation, of course, even in the other situation, but it can be enhanced and improved in the simulation, whereby when you have a problem to solve, you also work together to get the involvement of the other team members, have the point of view of everyone, and they get a consensus and get an informed decision with regard to the problem that was identified. Thank you. So I would say that simulation as a strategy to enhance interprofessional collaboration, it's a strategy, as we said, from literature and from experiences, that it improves communication, which is a key for a team functioning among multidisciplinary team members. And just I have said that it also fosters decision-making, shared decision-making while we collaboratively think about the different option of solving a complex situation, and you take a common decision. So, of course, this would be also important to highlight the clarification of professional roles on a team, on different team members on a care. And the other, it's about resilience in the case of crisis, as I said, whereby you have continued professional support and recurrent. If there's an error and or conflict that you have, it's a simulation. Though we simulate a real world situation, but again, from what we just said, from the debriefing, we would come back and see what wasn't done well and get to correct it as it is in a simulation. Thank you. So this, I want to talk about different approaches, not limited to what is mentioned here, but I know we have different background, different situation. But if I can say what is common, it's the use of standardized or simulated patients to work on role playing or discuss on case-based scenarios, like clinical cases, and then we can have this simulation, a simulated patient who can role play those cases. We also have the high fidelity simulation mannequins. Not maybe all settings would afford that, but we know also that they're very, very important, though they might be costly, but they also help very much in this situation of training multidisciplinary team or interprofessional collaboration. The other strategy or approach, we just talked about virtual simulation, e-simulation, and in previous session, we were talking about structured debriefing sessions, to name those. Please, the next. Thank you. So we would not say that it's there without challenges. There are challenges that have been highlighted, and that we also face in our settings, different settings. So the challenges mainly that would be there would be resource demand. So having a simulation, functioning simulation setting, you require resources that might be always there. So that's a challenge, a big challenge, where you need equipment, but also you have trained faculty who can support in the training. Interprofessional collaboration. And and the other thing which is also important to raise is the resistance, whereby you have some of the health professions would stick on their siloed training programs. So matching or scheduling across the profession it is challenging anyway. So those are the challenges, the faculty that I said, and the support that is needed. Those are considerations also to highlight, to make the simulation, as functional to support interprofessional collaboration. Next. So just I know that we have been talking about this since the morning, so I found myself repeating what others said, But this is very important that for a simulation to be functional and support interprofessional collaboration for future collaboration or ongoing collaboration, if it is a continuous or in service, if not in pre-service, we still need institutional support. So institutional support, as we have seen, that some of the challenges will require to have a budget for the resources, the equipment. So that, and even getting it, recognized and supported as a strategy itself. So this is something that I would want to highlight as well. Integration of virtual, we have said it, but although it has also its weakness or something to improve on. And I would also say about the inclusion of interprofessional collaboration or education and simulation in the curricula. Because I have raised the challenge of having resistance for the slowed programs, it's important if you want really to enhance and strengthen this interprofessional collaboration, to start it, to strengthen the pre-service education, the interprofessional education, and to get it into the curriculum. And of course, we talked about interprofessional training for patient safety. There was a talk on that, so I'm not coming back to it. But again, I have learned, and we have learned about the example that was shown, that we learned from the medication, the confusion between the vaccine and the medication that was in the fridge. So that means that if there's a strengthening of enhancing the training or getting the training on these different competencies, including clear communication, secure communication, pressing the information, the role of each one, and the support as a team, like the team leading. Those are things that health professionals need to really gain, and this can be done strongly in a simulation environment. As I conclude, I think it will be the last one. It's about simulation is more. That is the last next is, yes, thank you. I want to say that simulation is more than a teaching tool. As we use it most of the time, it is a powerful tool to foster interprofessional collaboration, because it bridges, it's a bridge that connects the professions, professional across the discipline, different discipline, and it's really leads to improve safety and the care, quality care of the client or the patient. So it's a brief, but I wanted to thank you for the opportunity to be speaking to all of you about what I think on the use of simulation and enhancing interprofessional collaboration. Thank you.
Thank you very much, Dr. Wimana, for your illuminating presentation, where you brilliantly highlighted the importance of simulation in fostering interprofessional collaboration and work. While waiting for the interaction from the audience, I'm curious about your personal experience in Rwanda, because, you know, our countries share some common conditions, and we know that we use simulation more in education than in continuing medical or professional education. So we have this problem, like the health professionals do not study in the same institutions, they're not even being in the same universities. So it's a big challenge for us to organize simulation-based training that would integrate different course of healthcare professionals. I don't know how the case is in Rwanda and in other African countries, based on your international and African collaboration. What can you tell us about that?
Thank you so much, Mariam. Maybe if I start with my experience and what is from our side, I would say that it is challenging, very challenging. We don't have that time of getting different health professionals from different discipline together to bring them in the education. So even the collaboration itself, collaboration practice, beside even the education, even the practice itself, collaborative, it still have challenges. So we still have some professional who would come and they do their job, and I would say even this hierarchical, I would say that where you have medical doctors will come give order, and the nurse have to few hospital, like a teaching hospital, you will have discussion around the case. In the profession, in the practice, but going back and taking this on service training, it's challenging. So we're not there yet, but at university, like University of Rwanda is the main university that trains different health professionals, that including medical doctor, nurses, and the other allied. We have, like, since last year, we trying to get how to bring them, at least have some exposure, like getting together for some modules to be trained together, but we still funding ourselves. We don't have it. Though we have had some of the session where we brought the residents in the obstetric and the gynecology with midwives. And this is for the classes, it's in pre-service, like the residents and those who are in the obstetric and gynecology with our senior student midwives. Those are the example that I could give you, but it's really challenging up to now. Thank you.
Okay, thank you very much. I can see that no other questions are coming right now. And how about practicing this simulation to foster how to improve the interprofessional collaboration within hospitals, in the workplace? Do you have any experience on that?
The experience, I would also say that it's not something which is often, but we have the hospital with the simulations setting, especially the teaching hospitals. So at some point we will have, yes, like a different discipline, like if you have anesthesia and anesthesiologist and the nurse anesthetist and like those critical care nurse would have some sessions. So it's not like a systematic, but it's done once a while. Yeah.
Okay. Yes, just like what we do, like every time it's possible to put health professionals from different backgrounds together around the session of debriefing or simulation, be it in the institutions or in healthcare settings. We do that in order to improve their exchange and collaboration. Thank you very much, Dr. Uwimana, for your participation with us today. And Yes, and I would like to, last but not least, I would like to welcome our third speaker from Morocco this time. Fatima Zahra Al-Esri is a nurse, anesthetist, and educator at the High Institute of Nursing Professions and Health Techniques in Rabat. With over 15 years of experience in anesthesia, resuscitation, and nursing education, she combines clinical expertise with academic leadership. She specializes in simulation-based education to improve human factors, patient safety, and decision-making. She has created innovative curricula on non-technical skills, such as teamwork, situational awareness, and crisis resource management for her students. Her recent work highlights the use of simulation to reveal cognitive biases and to strengthen safety culture in healthcare, and she will be talking about this today. Welcome, Fatima Zahra. Your mic, please, Fatima Zahra, activate your mic.
Okay, so good afternoon, everyone. Good afternoon, Professor Fortassi. Thank you for your kind introduction. First, I'm going to share my screen. Okay, can you see it? Okay, so it's a real pleasure to be with you in this great event of the Morocco team, and I would like to take a moment to thank sincerely the Morocco team for what they are doing and for giving me the opportunity to share my passion about human factors. I would like to address my special thanks to Professor Mouhawi and for you, Professor Fortassi. So today's topic is something that talks to all of us, whether you are a doctor, a nurse, or a health provider. And as a nurse, I have encountered many challenging situations where decision-making have to be made. So discovering cognitive biases was a game changer for me. It opened my eyes how my brain can influence my decision-making. So I'm eager to share how this awareness can benefit all of us. To start, this is the roadmap that we will follow together and to break down this topic and to answer to these questions. We will start with the basics. What is a cognitive bias and why should we be aware of it, and which ones are the most prevalent or the most impactful in our practice in healthcare, and when they are likely to occur or to happen. And finally, we will explore together how we can mitigate them and reduce their impacts. But first, to warm up our thinking, I want to start with a quick challenge. So but I need your interaction. I kindly invite you to share quickly your answers in the chat box. So this is a CT scan of length, and I want you with white spots here. There is some white spots, and I want you to take a look and tell me, did you notice anything unusual, something awkward or unusual here? If yes, what is it? And if it's no, it's no. I will check the chat box. Okay, I can't accede to the chat box. Can you help me, Professor Fortassi?
Yes, if there are any answers, I will let you know. But
okay.
So far, we didn't have many
so
answers.
What is it?
Just proceed. Yeah.
So I will give you a sneak peek. No medical knowledge is needed here. Is there some answers?
Not yet, but I can answer.
Okay.
So I can see some weird picture.
But don't spill the beans.
Okay, fine.
Okay, let's have the answer because we don't have much time. So
Yeah.
Actually, there is a gorilla embedded in the right lens. And this is not a joke. It's a real study that was carried out with radiologists. And imagine that the hidden gorilla was larger than the white spots. And even 83% of expert radiologists missed it. So what I tried here I made this exercise for a purpose. I tried to anchor you into the white spots so no one could see this gorilla. We can't focus on anything else of these white spots, because I try to apply what we call the anchoring bias, and subsequently we will go to an intentional blindness when we can't focus on anything else. This exercise or this challenge, I made it for a purpose to show that sometimes that we don't need knowledge, or we don't lack knowledge, or we don't lack intelligence. We are not bad doctors or bad nurses. It's just our brain is playing tricks on us. We are processing information differently and we make errors. That's why we need to understand why we make these errors and how to reduce them. And this leads us to our key concept topic, which is what does it really mean, a cognitive bias? So it's basically a mental systematic pattern of deviation from rational thinking. It's a kind of flaws or distortions in our reasoning. What we can see doesn't outline always what we understand. So let me explain it in this way. Imagine your brain is like a plane flying on autopilot mode. When you are making a decision, you are relying on patterns or familiar patterns, habits, or what you expect to see. This autopilot can save time and energy, but it can lead to errors. And this is typically our system one of thinking. So if I ask you what kind of car it is, you might say, obviously, it is a Mini Cooper, but this is a limousine. And this is how a cognitive bias may work. So let's put all these in our context. When we are faced to a clinical problem, we are processing information into different ways. We either use the system one, which is the autopilot mode, or the system two. The system one, which is the fast, like a rabbit, automatic, unconscious, pattern recognition, but more prone to bias or these errors. The system two, the logical, or which relies on logical thinking, is slow like a turtle, deliberate and safety net, but it's effortful. In our practice, we rely more on the autopilot mode, where the system one, because it handled more than 95% of our thinking. So the main idea or the key here is to know when to switch from system one to system two, and when to know to apply the debiasing strategies. The debiasing strategies are the tools to reduce the impact of these cognitive errors. So the bottom line of this presentation is that if you master these two techniques, you will be able to improve your decision making, to improve the diagnostic accuracy, and to reduce the errors. So now let's see some examples of cognitive biases and how it can show up in our practice. So the first example will be about the availability bias, which means when we rely to the information that are readily available in our mind, or in other words, the information that are easy to recall. Look at here, the yellow circle. We have all the information. And when we are making a decision, it will be based on the recent, frequent, negative, extreme, or emotionally sticky information. So let me give you a clinical case of availability bias. A general practitioner has seen recently many cases of gastroenteritis. So one afternoon, a 35-year-old woman comes to his office with abdominal pain, nausea, and low fever degree. So the doctor was thinking, oh, it's probably just another gastro case going around. So he prescribes hydration and some rest, and the patient goes home. But 6 hours later, she rushed up to the emergency with ruptured ectopic pregnancy. So what happened here? That the doctor based his decision on the information that was frequent on his mind. So he assumed that it was consistent with the symptoms. And this is what we call unavailability bias. So let me give you another example of a powerful bias that reported in studies that it impacts all health providers. So it's the anchoring bias. So it means that when we rely heavily to the first information that we receive, even others' information suggests something else. We just stick to that first impression and we don't adjust, like the anchor here attached in the foot. We cannot remove it easily. So another example, a 55-year-old man comes to the emergency with chest pain. So he is anxious, fast breathing, and stressed. So the triage nurses comes to the doctor and tells him it's an anxiety attack, no previous cardiac history. So the doctor examined the patient and looks and checks the ECG that looks normal. And he thinks that it's certainly a panic attack. So the patient was discharged with anxiety medication and goes home. But this time, 2 hours later, he came back with cardiac arrest. Why? Because I repeat, ECG shows a full-blown heart attack. And what happened here? It's the doctor that was incurred into that first impression that it's just like a panic attack, and he couldn't see others alternatives. And this is what we call the anchoring bias when it show up in our practice. So now let's understand why does it really matter. So according to this study, cognitive biases and its influence on clinical diagnosis, there is up to 3 out of 4 diagnostic errors were linked to cognitive biases that highlight the need to take it seriously. And there is more than 70 of the studies reviewed found a link between cognitive errors and therapeutic errors. That means that it doesn't only affect our way of thinking, it can also influence what we do and our actions, such as prescribing treatment to our patients. And it can also influence all the stages of diagnostic processing, from information gathering, making or interpreting the disease, understanding the context, checking the diagnosis. And this is not an issue of physicians. Decision-making of nurses can be affected as well in many areas where nurses may work. For instance, pain assessment and management. Some nurses can underestimate the degree of pain and give unequal treatment. There is also the triage scoring, evaluating the degree of the urgency. We have also recognition of deterioration, escalation of care, screening and treatment decision, and so on. And the consequences are serious. It can lead to death or can harm the patients. So now let's discover which ones are the most prevalent or the most impactful in the healthcare practice, referring to studies. So the finding of this study about diagnostic errors due to cognitive biases among physicians in Japan highlighted that the anchoring bias, the premature closure, and the availability bias were in the top of the list. The premature closure means when we accept a diagnosis too early without fully verifying it. We just accept and stop thinking about it without verifying it. So these three were in the top of the list besides others. And the same thing for nurses in the triage decision in the emergency department. The anchoring bias stands out first and foremost, besides others like the availability bias and negative framing. So let's now explore when they are likely to occur or to happen. So these errors due to cognitive biases, when they can happen. So referring to the same study in Japan, they can occur in the emergency room, at night shifts, during the day of the week, from Monday to Friday. Why? Because when the stress, the fatigue, the workload, or the pressure are high, the opportunity of cognitive biases double. Because we are pushed in our autopilot mode, we are just relying on pattern recognition, relying on heuristics. That's why we need to manage the stress and the fatigue in our practice. Now, let's figure out how can we reduce these errors due to cognitive biases. But first, I need to draw your attention to something, to a point super important to consider before to move on to the next step. Right now, some of you may say, yes, cognitive biases are interesting, but they are not my problem. They affect other people, not me. My decisions are rational and well-reasoned. So this is in fact a blind spot bias. You keep saying everyone biased except me. It means that you are blind to your cognitive mistakes. You can see the others, but not yours. That's why we need to switch our mindset and to acknowledge this vulnerability and to consider that everyone is concerned. This is our human nature. And recognition is awareness. So for strategies for changes, I came across these insightful studies that mapped out some structured strategies. For instance, educational and workplace strategies, enforcing functions. So let's explain it. So we can memorize them, like name it for education, name it for workplace strategies, and force it for forcing functions. So the first approach focuses on educational strategies to raise awareness. How? By incorporating in the curricula the theories of clinical reasoning and decision-making. And also by improving the bias inoculation, by getting the students immune against this bias, by getting them practice a lot of clinical cases about cognitive biases to recognize them and to spot the cognitive traps. There is also the practice of the simulation training in a real life, with a real life scenario in safe environments, which is in fact a powerful tool to uncover the cognitive biases. So referring to this study, students during simulation can be able to identify the most frequent or the prevalent cognitive biases, such as the anchoring. Why? Because simulation works as a mirror. It makes our hidden thinking traps visible. Thanks to the debriefing, it can make them aware of their clinical reasoning. So let's come back to the second approach about workplace strategies, which means that we need to implement some tools in a real time decision making, because pressure and stress can push us back to make cognitive traps or errors. So we need to use, for example, checklists and structured reasoning to avoid, for example, underestimating or overlooking some information that can influence the overall accuracy. There is also the slowing down strategies, which means that we need some tools to pause and reflect on our decision and ask ourselves and ask our assumption, what else could it be? And it's not about just a pause of few seconds or few minutes. It's like a mental reset. So the tool is the group decision strategy, or seeking for the second opinion. We need to rely more on the teamwork and to try to seek for the others' perspectives, because it can helps us to avoid the blind spot test, the blind spot bias, and also it can increase the diagnostic accuracy up to 30%, referring to some studies. And finally, we can also rely on clinical decision support systems. That means we need to computerize the data of the patient that can enable physicians, for example, to have recommendation and alerts when there is some errors. Finally, we have the forcing functions, which means that we need to establish some rules while teaching our students or in our hospitals, to force us to think beyond our first impression, and to think deliberately about what goes beyond the first impression that we have. For example, we can roll out the worst case, or always broaden the differential, or maybe never miss meningitis in a febrile child. So with this forcing functions, we can activate our system of thinking. So remember it as name it for education, tame it for workplace strategies, and force it for rules. So to wrap up, I want to share with you our experience and our institute about teaching cognitive biases with simulation. So we combine just simply short theoretical courses with practical low fidelity, and the scenarios was designed to highlight the most prevalent biases. So it was about rare decision, nursing diagnosis, and managing complication. And the learning outcomes were very promoting, because students become more and more aware of their biases and practice these strategies to reduce their impact in their clinical training. So to conclude, if you only take home one message, let it be: biases are real, abundant, and predictable. And because they are predictable, there is ways and opportunities to intervene and to manage them, to build the safety of the patient step by step and action by action. Because our responsibility is to strengthen our safe culture and to switch into our mindset and expand our safety toolbox together. So let's commit here and now. Let's think smarter and act safer. Thank you for your attention, and I'm sure next time you will catch the gorilla.
Thank you very much, Fatima Zahra, for this brilliant and eye-opening presentation on cognitive biases. We really are honored and proud to have you in Morocco Scene as the lead of the Interprofessional Club. I can see many questions coming in the question and answer box. The first one is very interesting, and Khadija Himer, she's asking the following. Can years of experience act as a safeguard against biases, or are even experts still at risk?
Okay, thank you for this insightful question. It's very intelligent. Actually, experience is a double-edged sword. On one hand, it can give us pattern recognition through the library of cases that we have learned with the experience, and it can give us some confidence when managing critical situation. But on the other hand, we can be vulnerable to some cognitive traps, like the confirmation biases by saying that I've seen this diagnosis before. It can be this diagnostic, and they can be also they have some resistance to some atypical forms because they are used to their mental patterns about the diagnostic. So the best way is to combine the experience with the structured tools. For example, checklists to rely on the teamwork and to ask their assumption and reflect on their decision.
Okay, interesting answer. There is another question. Can slowing down strategies or checklists truly fit into the fast-paced environment of the emergency department? You know, cognitive biases are within the first system of thinking, and this is the system that's mostly used when we're in stress situations or in emergency situations. So how can we slow down at the same time, be efficient in the emergency?
Yes. The challenge is big because we have to manage the complication or the urgency of the situation, and at the same time we have to stay mindful about the cognitive biases. So the best way is to start with the slowing down strategies, like pausing and making some pause and asking yourself what else could it be. Because it's not just a pause of few minutes, it's like a mental reset. You are just thinking about your thinking, how to manage this situation. And you can devise the task if there is the team. Some can think about the managing this situation, and some can reflect and use these tools. But the best way is to get used to do these tools in the regularly or in the ordinary days of the shift. So you will build this habit to use it in the emergency. And also you have to rely on the teamwork, because you need to speak out loud your reasoning and ask the other's perspective. What do you think of this? So you can spot the blind spot bias just by having a huddle or a quick briefing with the team. And there is a super powerful tool when we get stuck into a complication or we cannot manage a problem. We have to apply what we call 10 seconds for 10 minutes. 10 seconds can saves you 10 minutes of complication to reflect on and your decision, and think, am I getting stuck into that first impression, and so on. And we have to try to use these tools, to get used to these tools to reduce the impact of these cognitive errors.
Well, thank you very much. As we're running out of time, I would like to thank you, Fatem Zahra, and I would like to thank all of the three speakers for sharing their expertise and experience in these human factors sessions. And I hope that today's perspectives inspire you all to apply these concepts in your own practice and teams. I'll now hand the session back to our conference host, Mariam, to transition to the next session.
Thank you, Professor Fortassi, and thanks to Professor Denis Oriot, Dr. Wimana Filomeni and Mrs. Leslie Fatem Zahra for your illuminating presentations and the fascinating discussions. We will now take a 20 minutes break. Please rejoin us at 1:50 p.m. for another amazing session 4, Innovation and Future of Patient Safety. This session will be chaired by Dr. Mohammed Derwish, our youngest member of the board.
بلاد في طنجة شوفنا في كازا نورا حقرونا سوا ما عرفوناش كنا الخطر هلا 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 تاسك فورس دايرين حالة ديروا النية وصلنا العالي تعالى هلا 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 تاسك فورس دايرين حالة ديروا النية وصلنا العالي تعالى يبدأ في طنجة شوفنا في كذا قالوا حقرونا سوا ما عرفوناش من الخطر هلا 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 تاسك فورس دايرين حالة ديروا النية وصلنا لعين جعالة هلا 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 تاسك فورس دايرين حالة ديروا النية وصلنا لعين جعالة
Welcome back. The clock strikes for session 4, dedicated to innovation and the future of patient safety. For our final session, it's my pleasure to introduce Dr. Mohammed Derwish, General Practitioner in Casablanca and Treasurer of Morocco SIM. He's also the former President of Morocco SIM Junior and has been actively engaged in simulation-based education and innovation. Dr. Derwish, please guide us into this session.
Thank you very much, Dr. Alami. I might be the youngest, but you'll always be the kindest. Now, without further ado, let's move to the fourth session, titled Innovation and the Future of Patient Safety. We are privileged to have with us 3 distinguished speakers, each bringing unique expertise and global perspective. Our first presentation is gonna be presented by the president and head of SSH, the Society for Simulation in Healthcare, Dr. Jared Cudzon, all the way from New York City, who will discuss AI in simulation, potential, risk, and ethical challenges. Dr. Jared Cudzon is a professor of emergency medicine and medical education at the Icahn School of Medicine at Mount Sinai, and Senior Director of the Simulation, Teaching, and Research Center at the Mount Sinai Hospital. He is a registered nurse with advanced degrees in health policy and management, public health, leadership, and medical education. In 2025, Jared was recognized by Baker's Hospital Review as a great leader in healthcare and one of 132 patient safety experts to know for his work in healthcare simulation, patient safety, and leadership. Please join me in welcoming him. Jared, the floor is yours.
Thank you. Thank you very much. And it's good to see everybody, and I'm happy to be here. Just want to make sure you can hear me okay? Everything is good?
Yes, we do. Yeah, we do.
Perfect. So I will share my screen, and thank you for that kind introduction. It's always nice to see the group from Morocco Sim. And so I was asked to talk today about AI and healthcare simulations, some of the potential, some of the risks, and some of the ethical challenges that we may see. And so I do want to begin with a disclosure, which is that I am not an expert on AI, machine learning, but I work in all of these and have had some work in publication, large and AI and innovations. And so we at Mount Sinai have a Center for Artificial Intelligence, and those are the researchers and the coders and the individuals responsible for it. But the AI reshape it and like any powerful tool for these evolves. And so,
excuse me, Jared. We think we're running into some hotspot problems. Can you change to Wi-Fi or hotspot? Because we can't hear you right.
Can you hear me?
Jared? Okay, he's back.
Okay, is that better?
Oh yeah, way better.
Okay. Yeah, as you were saying that, I know that we lost connection there. Okay. So let me go back to the presentation. And hopefully the connection remains strong. So
Yes.
let's share
Between the
the
time that
screen.
you share the screen and everything, we're very excited to be participating in SSH annual meeting next year, January in San Antonio. So I guess our next meeting will be there.
Yes. And so, okay. So what I was saying was that AI is not replacing simulation, but it is reshaping it. And like any powerful tool, it brings both opportunities and responsibilities to all of us. And so I'm curious, maybe there's a way in the chat or in the Q&A, or just by a show of hands, who here has already integrated AI into their simulation practice? And maybe you can raise your hands in the chat. I see some hands already. Okay. So one of the questions I always like to start with is, what do you see here? And you don't have to answer this out loud, but you can just take a look at this. And what is this image describing, or how would you describe this image? And what do you see? And I find that this image in particular, using prompts in AI changes the way in which the outputs occur. So if you were to go to one of the AI generators and type in AI in simulation, you may get an image that looks like this. And what I find interesting is if you write healthcare simulation, you'll get something around the neck, like a stethoscope, because that is the quintessential sort of picture that gets developed when artificial or augmented intelligence goes and creates an image for healthcare individuals. And then when you look at this one, what do you see? Right? And so we look at this and we look at maybe this individual who's not attentive. They might have a glassy look in their eye. Again, healthcare, there's a stethoscope around their neck. There's some interaction with virtual or augmented world that they are interacting with there. And so, the visuals of AI and health simulation are
Dear Jared,
significant.
I'm sorry to interrupt you again, but dear Jared, sorry to interrupt you again, but it's the same problem.
The AI-powered patient avatars that using ChatGPT or other to enhance the dynamic model. Again, Wi-Fi.
Yeah, I'm sorry, Jared, but we're running into the same problem again.
Problem. I don't know if I have a stronger Wi-Fi current location. Let me check off now. Let's see. Is that better?
It's still seconding. It still breaks.
Huh. Is lack of video any better or no?
We see perfectly the screen sharing. We see it, but when
If
you
I
talk,
can move
we can't hear you right.
One other location.
Okay. So until Jared gets connected to us, let me just give you a kind reminder of our presentation that we'll be discussing today. We have three distinguished speakers, starting from New York City, USA, with Jared, who's gonna discuss AI. And then we'll be moving to Toronto, a very quick trip with Dr. Faiza Javin. We will be discussing gamification and XR. And then we'll take a very, very long flight to Saudi Arabia. And I'll take time to congratulate both of us, Morocco Sim and the Society the Saudi Society for Simulation in Healthcare, for our latest affiliation with them. We're very, very proud of our international network. And I'll just wait for Professor Al-Atassi at the end to give us a word about the affiliation and all the amazing opportunity this will offer us all.
Okay, so is this any better?
We can see it fine, but the voice is always a problem. In the audio, there is always problem.
There's always a problem with the audio. That is very interesting. Let me try. Let me switch devices and see if that'll be any better. I'll be right back. Give me one. You know what? Let me see if I can do this on here.
I don't know if he's. I just want to check if Professor Jabin or Professor Al-Atassi are present, so we can maybe give you some time to adjust and move to the second session. But I know Professor Jabin will be connected around 2 p.m. Yes, here. Jared, is it okay with you if we give you some time to adjust and start with the EPSS president?
Absolutely. Go ahead.
Thank you very, very much.
Thank you so much for I am not able to follow each and every presentation, but I was following in between and comments and everything. So a huge congratulations on the SIM conference holding. And then also I'm very happy to talk about or congratulate the Moroccan Society on a recent affiliation with the International Pediatric Simulation Society as well. So with that, I will be talking in the next 20 minutes about the gamification and XR and how it is revolutionizing, a little bit more focusing on the quality improvement. I would
Professor, I'll just steal the attention for 1 minute to introduce you properly.
Sure.
Correctly. So we're sorry about this delay. So we're gonna start with Professor Jabin Faiz from Canada, Toronto, who's gonna be presenting gamification and XR to boost safety competences. Dr. Jabin Faiz is an associate professor of pediatrics and medical director of SimKids at SickKids in Toronto. She's internationally recognized in her leadership in simulation, faculty development, and global health education. She has led numerous research projects on resuscitation, team dynamics, and system testing, and has played a key role in building simulation capacity worldwide. Dr. Jabin Faiz, the floor is yours.
Thank you so much, Mohammed, for a kind introduction. So as I said, I will be talking about gamification and XR with a lens toward quality and safety and the role of simulation by some of the examples or case studies that we are doing at SickKids. So my learning objective is to talk a little bit about intersection of safety and simulation, what's the role of gamification and XR, and then go through some of the examples. In the pictures, you can see our amazing Sim Center building, as well as the team which I work. I would like to acknowledge that this is the work of many, many team members which are present around me or who are my enablers, and I will not be able to do all this work without their help. These are some of my disclosure, and with that, I would like to tell or start with a story which I really like always. We all know I will be talking a little bit more in the context of pediatric emergency medicine or acute care because of my own specialty and bias in the environment which I work. So we all know that emergency department is always chaotic. You never know what walks into your door. Multiple sick patients, clock is ticking, the stakes are high, and the high pressure moments are there where you have to perform at your best. So to be prepared for that performance, traditionally what happened? Like when I was being trained as a pediatrician and then as a pediatric emergency medicine physician, what is happening that whatever case I get, if I'm lucky, I got a chance to practice intubation on the actual patient. If I'm lucky, I got a rare procedure. So this is the traditional way that whatever you get, you learn. Another traditional way is do a C1, do one, the apprenticeship model that our senior physicians or nursing colleagues teaches us. But with the invention of the simulation, which is like now many decades old, but think of countries like Pakistan, where I was trained, simulation it's still very, very novel stages. So simulation was introduced, and then it is a game changer, I would say, which turns the practice to mastery learning. That's what is being focused the whole day. You have learned many, many ways that simulation is influencing our clinical environment, our healthcare flows, and how we perform. Why safety matters and competencies in safety matters in healthcare. We all know why we become doctors is to provide best care to our patient, to have an impact on the patient's and family's life. So whatever we do, whatever our actions are, has a direct impact on survival rate, recovery quality, as well as the errors. The cost of medical errors is in millions and billions. So if we want to do a cost reduction or return of investment, probably investing in simulation is a better idea. And then definitely both quality improvement and simulation provide an environment where there's a continuous learning is happening with a feedback loop, which is always in place. So if we look at how QI and simulation synergizes each other, I would argue with you all that both put safety first. I know that conventionally it is thought that simulation is for teaching and learning, but now there are multiple examples in the literature, in the healthcare case studies, that simulation is much more beyond teaching and learning, and it's about creating safe environment for the patient care. Both quality improvement processes and simulation optimizes the spaces and team in a way that they work cohesively in a time crunch and with all of its like the environments are never been perfect, but to work perfectly in those imperfect environment. Third, provide valuable feedback and guidance. And then the fourth one is integrating multiple skills. You can work in a team, you can work as interprofessional team, multidisciplinary team, and you can learn about leadership, communication in addition to medical management, and you can just incorporate design thinking, human factors, whatever you want in a single scenario, and that's what quality improvement processes are. So what is the current landscape? The current landscape is they both are working in silos. Like all of this is happening in the quality improvement realm and in simulation world as well, but they are working in silos. So what is needed is a perfect integration where quality improvement and simulation is in the middle, and education, learning, technology, system process testing, and human design thinking is revolving around it. So if we are able to develop this, then I would always say that in quality improvement, they say plan, do, study, act. I would say plan, do, simulate, and act as well. Why can't they work together? And by doing that, QI strategies and simulation working together, we will go from present situation to ideal situation. In now, this, like I would say in last 5 to 6 years, there's a very huge boom of technology and innovation, and Jared will talk about a little bit. I'll talk about a lot about AI, so I will not be touching those areas, but the traditional methods are not enough for this Gen Z, which is a new generation. They want more. They now do not want to work just with the mannequins. So if we look at the acute care training, especially the PEM training, we all know that this is how our EDs look like. We do not have much time to teach them. Then there are sick, ill trauma patients there where we will have to work as a team and provide them the best possible care. So therefore, this gamification and XR is kind of getting their more and more popularity. And if we talk about them separately, gamification is a combination of game elements with combination to real world tasks. And what are the game mechanics? That there will be a competition, which is a healthy, psychologically safe competition, competition with some points, achievement, badges. There will be a progress tracking, and there will be a competition, but that is a healthy, in a psychologically safe environment, which will lead to transformation of a routine safety training into interactive challenges, which enhance the learner's engagement, motivation, and also literature has suggested retention rate as well. While you look at the extended reality, which is getting popularity, is kind of a mixture of virtual reality, augmented reality, and mixed reality, where like either you are completely detached from your actual environment and performing into a total virtual environment versus your current environment get enhanced by the augmented reality or mixed reality. You may think, why gamification and XR? As I said earlier, today's learner are increasingly drawn to interactive hands-on learning experiences rather than traditional lectures and traditional simulation. Gamification taps into this preference by offering a more engaging participatory approach. By creating a safe yet competitive environment, gamification and XR support experiential learning where a learner can practice, make mistakes, and improve without real-world consequences, but with having fun, which will increase their engagement. Interestingly, when I was doing the literature search for my presentation, when I put gamification in healthcare education and I put anytime, there are almost 34,400 results come in. So there's a lot happening in gamification. When I put in last 5 years, it is still 17,500. And then in this just 2025, 9 or 10 men, there are 10,500 studies which are happening, which are being published into gamification. So you can imagine how much rise is on the go about this methodology of using in simulation. So a couple of articles which I want to highlight. One is the one which I was part of it along with many, many colleagues, where they compare a difference between gamification, serious game, and the intersection of them with simulation. So I highly encourage going through this article, which is a review article, and it will provide you the foundation, as well as if you want to incorporate what are the aspects that you need to be aware of. The second article, which is literally not very recent, it is from 2014, and it is kind of a letter or a small short communication in the by the surgeon, where they talk about, if you look at this graph, that at the blue dotted line, they introduce gamification. That is some tournament in the surgical teaching, and you can see how much the engagement has enhanced over time. So you can imagine, if you want to capture the attention of our learners, it is one of the pedagogy that we can consider. And then from the nursing literature, there's a loads of literature or articles that I found. But why I put it them? Most of them are either review articles, are scoping reviews, or opinion pieces, or very low Kirkpatrick pedagogy. So it's still in very early stages. How different in comparison to other methodology, it still need to be thoroughly investigated and researched out. Coming to the escape room, I would say escape room is a room which is created to challenge the participant to unlock the medical mystery by solving puzzles and applying critical thinking in a fast-paced, engaging environment. So if you look at the healthcare escape rooms, it's a thrilling, interactive medical simulation designed to challenge not only their clinical knowledge, but also teamwork skills in a high-pressure environment. And I will give you some of the examples. This is one of the escape room, which is created to simulate the critical task of cleaning equipment between the patient bed beds. And it is for the nursing colleagues and for the cleaning services. So rather than telling them a lecture or a 10-minute hurdle, this escape room was created where they will be able to clean and then unlock some codes and able to solve. The second example, and you can see it doesn't require a lot of resources. The other example is the escape room, which is created to teach the fluid management in the pediatric diabetic ketoacidosis. They have to calculate the amount of fluid based on the patient weight. They have to fill this bottle and the ball will float with a code to the next activity. So if they have chosen the right amount. So see, it is such a simple way. And rather than saying how much fluid you will give, you will have created a fun way for them to engage and they will become more motivated. The third example is the IPAC, which is an infection control escape room, which is created to teach them how to don and doff. And they have to put in the right sequence that how they will don the PPE and how they will doff, and it will unlock some of the puzzles. We get a huge feedback, like a very positive feedback. You can see the knowledge improvement happen from 62 to 87% with a lot of positive engagement as well as positive learners experience. And that motivated us to create a immersive escape room for pediatric emergency medicine quality and safety. We have a room which is developed on a cave technology where the whole room can be converted into an interactive space by 360-degree videos and hotspots on the wall. I will like to show you a video which will explain it further. And we are currently developed and piloted the PEM safety escape room on this pedagogy.
Welcome to our immersive multi-purpose room. Interactive projection technology immerses users in realistic simulations. From busy critical care units to our own sick kids CT scan room, helping our clinical teams practice safe, patient, and family-centered care. Our acute care transport service simulates realistic scenarios above the clouds.
This is a helicopter transport and a subway that we put as a 360-degree video, and the room get converted into a helicopter space or a subway space.
And you can even prepare for an emergency response on public transit. We run engaging, team-building exercises, such as our high school workshop for students interested in STEM, where students engage with quizzes to learn about medical terms and equipment. Or emergency scenarios practicing the care of a child, from ambulance to emergency room. To our latest venture into escape rooms, where learners solve educational puzzles and quizzes. To escape.
So this provide you an idea that how
Welcome
we're
to-
using it. And then this is our project where PEM safety escape room. And along with that, we are also testing that how can we modify the pulse debriefing framework to debrief the escape rooms. And this is the first pilot that happened, which really showed that how it increases the engagement for the fellows who are come from all over the world. And this is the study team. The second project, which I want to quickly go, is the integration of the CPR coach role. We all know that the recent PALS guideline have highlighted having a CPR coach in the resuscitation team member. And therefore, we plan to implement a CPR coach role into our resuscitation teams, which is all simulation based. And I will skip this video for the sake of time. These are all our CPR coaches who are trained. So the training not only was rated very high, but I would like to tell you that how we incorporated the later on the extended reality. First, we improved the process of notifying the CPR coaches by incorporating a CPR flare workflow, where like an Amber Alert, the physician or CPR coach who is on call get alerted, and it shows this kind of noise, this kind of sound, and their whole phone screen get converted into this, and it is written that a CPR coach is needed on specific bed number and the side of the ED, because our ED is quite big. Then we are getting engaged with the Johns Hopkins on a study which is on augmented reality CPR glasses. It's a big multi-center study, and we are the one of the Canadian side where the person who is doing a CPR will get a CPR feedback through the glasses that the person is wearing. So this kind of feedback will be shown on their glasses and will provide them feedback of either if they are compressing too fast, depth is less, etc. And then based on that feedback, they can adjust the rate and depth and improve the quality of the CPR. The project is undergoing, and we are very soon will be sharing its result. The other thing which is happening is about the AI-driven virtual simulation scenario and patient interaction, and we are doing it with this platform which is called Affinity Learning. If you want to scan the barcode, it will take you to the Affinity Learning platform. The good thing about Affinity Learning platform that it can create an interactive learning experiences where you can not only solve the scenarios, but you can interact with the avatars either or verbally or through the chatbots. It's mobile friendly. You can access it through your cell phone, through your iPad, through your laptop. It has a responsive vital simulator. You can put interactive 3D or 2D pictures with hotspots in it. And then the good thing is you can have natural language conversation within those scenarios. And the most important thing for us as an educators are you can also track the reporting and completion rate of the different learners when and how much they have completed. So these are some of the cases barcode, and I'm happy to share it with the Morocco SIM team, and they can share it with you all if they have your email addresses. And the community website has almost more than 100 cases, which are free to access. You do not have to buy the subscription. It's only if you have to create your own cases that you have to buy the subscription. I just have a few more slides, and then I will be finishing. All this is amazing, but there are some challenges and limitations to that. First biggest challenge is resource, and resource is in terms of investment into the development of those platforms and the development of the faculty. Who will develop them, who will test them, who will show that what impact it is bringing to the learners. And definitely there are some technology barriers. We are not equally good. We all are not. I have to learn so much when I'm doing all these projects and have to invest extra time and extra effort to learn about these projects. So the best practices for adopting these technology is always having a multidisciplinary collaboration rather than starting from scratch. Learn from others, reach out to your colleagues, reach out to your collaborators and learn from their mistakes or from their learnings. Iterative testing with continuous refinement and documentation of the learning outcomes is very, very important to continue to adapt these technologies and to document that what is the return of investment, because these are not cheap technologies. These all require your faculty time, but also huge investment in terms of dollar. Adapting to local context. The content which I have developed in Canada will not be applicable to my other global collaboration in Pakistan. We have to adapt them to the Pakistani context, to the Pakistani diseases and epidemiology, as well as the languages and cultural context. So I would say, start thinking about, we cannot shy away from all these technologies. We cannot close our eyes and we say, okay, this is not for us. They are going to come. We have to integrate, but then we have to integrate them in a logical fashion and be the first one to test them and to provide recommendation for others, rather than other industries providing us recommendation by doing rigorous research. So I know I have provided a lot of information. If you want to follow us on social media, our SimKits, and want to know other amazing things what we are doing, please connect with me, follow our page, and I will be happy to provide you more information. As well as being the president-elect of International Pediatric Simulation Society, I would like to plug in that join IPSS. It is free for low middle income countries. And then we do have an academy where there are many courses are offered along with a fellowship, which is a 2-year fellowship where IPSS and Inspire in combination provide you funding for you to complete your research project, as well as travel and attend either IPSS annual conference or IMSH to present your research. So, and our next year annual conference is in Rome, Italy. So please, the abstract calls are open. Submit your abstract, plan to attend, and then this is my email address and my LinkedIn page to continue this connection. I will always say when I present these presentation that it is the start of a collaboration or family building, and we are developing this community of practice where we all can learn from each other, collaborate together, work together, and be better each and every day. Thank you so much.
Thank you so much, Dr. Jabin, for your illuminating presentation and for the amazing work you've shown us that you're doing IPSS and in SIGKIT. We in Morocco work a lot in gamification too. We have a lot of articles been going on and work doing it. And one of our latest is a publication that will do Professor Mohawi, my mentor, and I, and it's about creating escape rooms in emergency medicine. Wow. And we're gonna be publishing a book about enigmas and escape rooms in emergency medicine.
Very
in
nice.
Multiple fields.
Very nice. Please let me know if I would be of any help. That will be amazing. And I come across that even using the Google Slides and Google whiteboards, there are escape rooms being built, and they are very, very low cost, low technology, and you can even offer it virtually as well. So there is a huge potential, and there is some gaps that you can fill out by using gamification.
Yeah, exactly. And as we say, the cost is always a problem. But as Gaba said, simulation is a technique, not a technology. So we don't have to go all in and all out to have something very nice. One of the questions I get asked always when I talk about the subject of gamification or XR is this. Can gamification in XR really change safety culture in hospitals? Or are we just changing and upgrading the packaging of all teaching methods?
That's a great question. And I would say if we are saying only gamification will change, so my answer will be no. It will be a combination. And we all know that when we talk about safety culture change, it requires a combination of elements like methodologies, as well as combination of teams working together. And one of the method to train and provide education is gamification, and it will require more into integration of your clinical flows. And I would say it should be how we are doing it. We are combining it like we have team training in situs. So in team training in situs, we are finding some gaps. The gaps are people do not know how to access the safety reporting system. People do not know how to access the protocols or pathways, or there are medication errors. So those partly we are covering from PEM Safety Escape Room. That is kind of a part of it. And then we will, when we do team training in situ continuous basis, we will see whether what has been taught through gamification, is it being translated into team training in situs or not. And now from January 2025, we started to actually record actual resuscitation, that is through the medical resuscitation video reviews, and we are reviewing, and that will close the loop whether those team training in situs learning are being translated into actual patient resuscitation or not. So I would say gamification is a part of the circle, and it will fill some of the gaps, but alone it will not tackle all the gaps.
Exactly. And we have a question in the chat from Ala.
Yeah.
He's asking, how do we ensure that gamification remains meaningful for learning rather than just entertainment?
I would say great question, fantastic, because you do not want to make it a fun activity and then all they are coming is just fun and laughing and then learning has not happened. So it will go again to the basics that even in creating a gamification, it took us almost a year to create the escape room. That what are our learning objectives, what are our learning outcomes, and how we are matching those objectives with the outcomes, and what are the games or puzzles or certain methods have been incorporated to achieve those learning outcomes. And then we are now also testing that how we can modify the Pulse debriefing framework where they will know, talking about each and every puzzle, that what is meant out of it and what was the learning objective or learning outcome was supposed to be coming out of A puzzle versus B puzzle.
Yes. And one final question from our YouTube is, and I think you've pointed out, is XR technologies are still costly and unevenly distributed. So how can we prevent gamification and XR from becoming tools for the privileged rather than accessible safety training for all?
Yeah, so that's again a great question. Cost is still a barrier for many settings. Even for us, we still do not have a lot of VR and XR because of the cost and the faculty time. So I would say being intentional. It's not that it is in fashion, so let's do it. It's finding out what is the problem you are trying to solve, and is it the best solution for the problem that you are trying to solve. And through our mentors and my colleagues who are more expert, I'm no way expert in VR and XR, they have said that if you have implemented a program using VR and you have invested money, if you are able to run that program for 2 years, then there's a return of investment on that. So the one benefit of your XR and VR technologies is that you can use it multiple learners in a very short period of time. So if that scalability is there, and if you are able to create cases which are easily journalizable, then it will be over the first 2 years, there will be a return of investment cost come back, because we underestimate our faculty time when we do simulation scenarios. When one simulation scenario is being run, it has a one educator, one sim specialist, a sim space, the sim mannequin. That has a cost, but it is so much into our culture that we do not take into account the cost of those sessions, how much it is costing. So I would say similarly with more advent of technology, and I'm pretty sure in the next 5 years, these technologies will be available for a much lesser price than they are right now.
Thank you very much. I will close this presentation by requoting what you said. We are creating a family and we are trying to collaborate the most. And this collaboration with IPSS and this affiliation, I think we're gonna be producing a lot of benefits for the healthcare community and simulation and patient safety. Thank you very much, Dr. Faiz Jabin, for your presentation. And if Jared is connected, can we retry?
Let's retry. Is this better?
Oh, it sounds better. It's promising.
Okay.
There is hope.
There is hope. My apologies for the technological difficulties earlier. So, you know, I'm gonna pick up sort of where I left off here, which is, and if you already heard this, I apologize, but this idea that AI is not replacing simulation, it is reshaping simulation. And like any powerful tool, it brings both opportunities and responsibilities. And I saw that you already raised your hand about who has already integrated simulation into your practice. And the question I was asking when you saw this picture was, what do you see? And just to think to yourself a little bit about what this image may mean to you and what this image may describe. And actually, I would be remiss if I didn't thank Jabin for stepping in and filling my time there for a few minutes. So thank you, Jabin. But picking up where she left off with this idea of artificial intelligence and escape rooms and all of these sort of technologies, you know, what I was saying when you're looking at this picture, you know, the prompts that you put into our AI generators is going to dictate what comes out of it. So if you put a prompt in something along the lines of healthcare simulation and AI, you'll get maybe an image that looks like this. And I don't know exactly what it's saying. It's looking like a robot, it's looking like a person. But what's interesting is that when you put healthcare into an AI prompt, you end up with this sort of necklace or stethoscope, which is sort of a defining characteristic of what is AI generates when it thinks or sees the prompt healthcare. And, there's futurism here. There's some sort of glasses on. So, some robotic component here. And then when you talk about AI and patient safety and healthcare, again, you get an image that looks like this. And when you look at it, it's at first glance, it sort of is inspiring and it makes sense. And then you look a little closer at this, and again, we have the stethoscope around this person's neck. But there's a coldness to the eye. There's a lack of connection. There's some technological thing going on with this handheld device with X-rays. Maybe it's relating to ultrasounds or some other devices that we don't even think about or know about yet. But how AI sees the world versus how we see the world and how we can sort of merge the two, I think, is a really important component. And so there's a lot of potential for AI in healthcare simulation. And part of that's enhancing the realism, using AI-powered avatars that respond to natural language, using ChatGPT or one of those other systems. And we're starting to see more and more of our vendor colleagues coming out with this content that is using large language models and ChatGPT type features to allow and enhance the realism of the communication. But it also may allow for more equitable care. It may allow for more realistic interactions of people of different backgrounds, of different languages, and giving people those other experiences that we can't do with just a standardized patient. I'm fortunate. We work in New York City. We have a wide array of patients that we can pull from and choose from. But if you're a medical student in another part of the world or another part of the country and you want to get practice interacting with people from different cultures or different languages, maybe AI is a more cost-effective, efficient way of doing that. Of course, the dynamic physiological models and adapting to interventions in real time is something else that we're starting to see. I was struck by a conversation I was having just last night with a colleague of mine. He's a president and CEO of one of the major healthcare systems, and he went and saw a simulation center. And he's knowledgeable of simulation, but wasn't super engaged or involved with it. And the simulationists who are showing him around were talking for the mannequin, and he said, "Is that AI generated?" And they said no. They showed him how it was done and how they did it, but that's the future, right? So voice changing and AI generations through our mannequins and realistic sort of conversations that we don't have to have necessarily somebody sitting behind the computer narrating the care and the case, I think is something that's very realistic. I know in my environment, being able to add different languages and different personalities. These are things that we're seeing in screen-based simulators, but we'll start to see this with, our mannequin-based simulators and probably some of those physiological modeling as well. We had done this a number of years ago. Some of our vendor colleagues had RFID tags that allowed you to recognize or allow the mannequin to recognize when certain medications were driven, and that would change some parameters. But I think the availability and the ability of those systems are much more improved today. And then more immersive and debriefing opportunities and other educational opportunities. But emotion detection, communication analysis. We're measuring heart rate variability in our learners and stress levels. And so we can start to see even more of this data being populated and utilized and helping us improve the way that we're providing our educational programs. And it helps us again, provide this more personalized learning. So as we're talking and thinking through this, do we have these adaptive scenarios that are tailored to our learners that maybe their strengths or their weaknesses, and we can modify certain scenarios with them? Do we have analytics that are used to help detect skills gaps over time? And then specific on-demand virtual coaches that we can then deploy, all things that can help improve the quality and safety of care because we're tailoring the education to the learner. We're starting to see this again. Some of our vendor colleagues have a smart airway, so it has a video camera in the trachea. It has sensors built into it. So what's the next step with that, right? Using that data, measuring, personalizing the learning, giving different versions of content to our learners, and then again scaling and access and equity. The low resource settings, AI driven virtual patients instead of our high cost mannequins. translation tools enabling global collaboration, and we see that in environments like today. We're, speaking to you all, and then automated case generation for diverse pathologies. I think that's a really valuable tool. So most of us have probably typed something into ChatGPT to help us create a case at the bare minimum. But I'm heading to Nepal in a couple of weeks and to other parts of the world. And so what are the specific case features that they're going to be needing to present to their learners? How do we create educational content to train the trainer that is specific and useful for the patient population and learners in developing nations and low and middle income resource countries? And using AI tools to help with that is certainly a time saver and gives us a general outline of which that we can follow. But there are certainly risks and limitations to it, and we have to be thinking about this. We all have had the interactions, if you've used any of these services, to see that the features may hallucinate or give you some incorrect information. And so it's incumbent upon us as the end user, as the human being interacting with the systems, to make sure that the content that's being generated by our AI colleague, partner, is accurate and reflective of what we're trying to produce. There might be physiological inaccuracies in some of the AI models, and so we just have to, again, be careful in how we deploy them and ensure that they're being tested in a rigorous fashion before deployment. And then we can't over-rely on automation. There's erosion of clinical judgment that may occur. And so we're starting to see this as we start to see people writing notes or using voice analytics for note dictation and then translating some of those key details into patient records and other components. We might start to see this erosion of clinical judgment, being able to formulate a note, being able to see the big picture and develop differential diagnoses. If you simply have a device that you can speak into and it spits out the top 10 differential diagnoses for you, are you able to then think through what those are really demonstrating and the next steps for it? And I think helping our learners understand the limitations of some of these softwares and some of these platforms is going to be really important for the next generation of healthcare providers to provide safe and high quality care. There's always the data and privacy and security components. And so learner performance data, right? How are we sharing this? Where are we storing it? And then are we allowing it to be used for machine learning, and what's the consent process and the anonymity components of this? And again, like I mentioned, sort of the training of the AI, and we have to be cognizant of the biases that may then produce. So AI is going to produce a bias because of the content that it's being allowed to utilize for its own learning purposes. And so then therefore is it artificially reinforcing those disparities that are common in our world today. And so we just have to be mindful that AI may continue to assist us, but it may also lead to disparities more prevalent. And then access gaps. Well-funded centers are going to benefit from this, again, widening the inequity and the inequality, and then therefore they're going to be putting the data into it, and therefore the AI tool is going to be spitting out data that is focused on those places. And so we just have to be careful of that reinforcing loop and make sure that we have the balancing loops to be put in place to help help refute that. And so there are some ethical challenges as well. And so, we have to be conscientious. Oh, let me go back. Mindful of telling our learners that when they're interacting with an AI versus a human, and making sure that we have good informed consent for data use in educational AI systems. There's a host of the AI tools out there currently, and so we see this in undergraduate and childhood education, where learners are using it to help them with their math homework, to helping them write their papers. And as a journal editor and somebody involved with sort of the research publication process, we have this challenge. We have these tools that can help you write papers, but is it original thought? And should the authors be allowed to utilize them? But if they have the original thought and they just had it wordsmith it for them because English isn't their native language and the journal wants the publication in English, where does that line get drawn between AI, creating the content and AI augmenting the content, and how much of that has to be disclosed? Is it really any different than a person editing it on the background for you? there's a lot of ethical dilemmas, challenges associated with all of that. And I think we just have to be conscientious and aware of this. And again, our learners have to be notified and explained to that AI was utilized or AI was involved in it. And then some questions, right? So should AI feedback count toward a summative assessment? I don't know. The research hasn't been done on this. Is it validated? Is it reliable? These are the same questions we've asked over the years, but is it more valid and more reliable than human beings scoring it? Inter-rater reliability is not what we think it is or hope it is. We see this in professional sports, right? We're watching, I'm a soccer fan, so I watch the referees and they have VAR, and we're looking at sort of some of those AI technologies. In Major League Baseball here in the United States, we have umpires, but now they're going to start to put cameras or utilize the camera systems that are there in the US Open and the French Open and the Australian Open. The lines are no longer called by human beings in tennis, but they're now, cameras and AI utilizing for some of those components. So high stakes, yeah, those are really high stakes. And so there is some concern about it, but maybe those are yes, no answers. Were they onside or offsides? Was the ball in? Was the ball out? But maybe in our world, their areas are a little bit more gray. But then again, did they wash their hands? Did they not wash their hands? Did they thank the patient? Did they not thank the patient? So there are yes and no's. There are binary outcomes that we can include. And then what are these algorithms, and are they transparent, or are they opaque and muddy and not clearly defined? And so, there's a lot of questions about, how are these machine learnings adapting and learning and continuing on? And so there's a lot of opportunities here for us to uncover and address and think through. And so as I wrap up here, I want to leave you with a couple of key points and some key questions here. And one of the questions is, if an AI simulated patient misleads learners, who is actually responsible for that? If our learner learned something wrong because the AI system has taught them wrong, is it the AI? Is it the human being? Is it us as the educators? And I think that we as educators have to remain the gatekeepers of accuracy and fairness. And I think we have to think about embedding these tools and utilizing these tools and making the tools more efficacious, but we are ultimately those gatekeepers. Another rhetorical question. If an AI debriefing assistant gives feedback that is accurate, but reduces the learner confidence, do you intervene or let it continue? I think if we flip this question around, if an AI debriefing assistant gives feedback that is inaccurate, but increases learner confidence, do you intervene? We all say, yeah, it wasn't accurate feedback. And so we don't want them to have a false sense of improvement, a false sense of doing something correctly. But if the AI gives the feedback and it wasn't done in the manner in which we would do it, or with the personal touch, and the learner leaves going, boy, I'm terrible, I shouldn't be practicing, but it was accurate information, is that a good thing or a bad thing? And there's a gradient there, and I don't think we have the answers to this. So I leave you with this. AI is a partner, not a replacement for any of us and all of us. So be innovators, but also the critical stewards of the artificial intelligence and the augmented intelligence that is coming out. But you have to engage in policy and accreditation and guideline setting for these technologies and these techniques that are going to be impacted through the technology that we see coming out there. The University of Arizona has been doing a lot of work in this area, AI and healthcare simulation, education and training. They're building learning tools for future clinicians and virtual patients. And these are some of the things that they have built. Their program that analyzes student-patient transcripts line by line. So this idea about feedback being given to a learner that is either too good or too bad or accurate, but the learner takes it negatively, or inaccurate and the learner takes it positively, it's being done. But what's our safeguard around it? The interactive SP, standardized participant, standardized patient communication tools, we're starting to see those are being built. Procedural assessments and checklists. So this stuff is not distant future. It's current practice in some institutions and coming down. And these are things that we have to think about. So I asked you at the beginning to think about and look at some pictures and to describe them. And I'm going to circle back to that for a second and ask you a question. When you look at these pictures, which ones of these pictures do you think are AI generated? They have numbers 1, 2, 3, 4, 5, and 6. Do you think none of them are? Do you think all of them are? We have a debriefing scenario in number 2. We have virtual reality procedures happening in number 3. We have a professional team doing a timeout in number 6. And so I'll share with you that they're all AI generated. They're all based upon different prompts that you put in. And so one of the most important things that we need to think about is not just dropping our content into one AI generator with one prompt, but utilizing multiple AI generators, using multiple different platforms so that we get a multitude of different perspectives, and we, the humans, take the parts and pieces that are most accurate, most reflective, and most specific to what we're hoping to accomplish as part of our educational curriculum. Our responsibility is to shape AI so that it becomes more than a technology and it becomes a force for safer, more humane, more equitable, and more efficient healthcare globally. This isn't just impacting those of us working in healthcare simulation, it's impacting all of us across the healthcare landscape, across the globe, helping us build bridges, helping us make tighter connections, but we have to do it responsibly and we have to be stewards of it. So thank you so much. I apologize for the communication issues earlier on. Thank you for letting me come back. And Jabin, again, thank you for filling the time.
Thank you very much, Professor Jared, for your insightful presentation. The least you can say it's very thought-provoking, and we can all see and agree why you are recognized by Becker's Hospital as one of the great leaders in healthcare. When you were discussing your subject, you started giving open questions, and it made me think of two things, and I would like to get your mind about the subject. Could reliance on AI in simulation inadvertently reduce critical thinking? Because if learners start tailoring answer to answer the algorithm, maybe they won't be critical thinkers after all.
Yeah,
and the other question is, yes. It's
so no,
I'll wait for the answer, then give you the
yeah, no, I mean, I think so, and I think what we're starting to see, is in the United States 15, 20 years ago, computers and electronic health records came out, and what we started to see was a bunch of clicks, and the ability to write a clear, concise patient interactive, note about the patient interaction has been reduced. But the process of going through and writing a note helps you think through about the questions you need to ask the patient. It helps you think through how you interact with them and what else is going on with them. And it's not just a bunch of click boxes. So I do think that as we see, dictation software, and not even dictation software, but AI that's sitting on your shoulder and listening and crafting the note for you, that it's going to change the way in which you're perceiving the patient, interacting with the patient. And so I do think it limits that critical thinking component of things, of course.
Yes, and the other question is, we all know that AI is based on data, but healthcare systems and simulation often deals with very rare and high stakes events. How do we ethically train AI without reinforcing bias or missing the outliers that matter most? Or in countries where training data sets are limited, how can we misinterpret the culturally underrepresented tongues?
I think that was one of the key challenges that we have, because as I said, when you are using an AI and you're artificially putting biases from the data into it, your output is going to have bias, and so we have to be thinking through and looking at what the data sets are and what's training it and how it's being utilized. But this is where the human element of it comes in. I think this is where it's not replacing the human being on the back end, but it's a partner augmenting on what we're doing. Because as you said, there's could be limited data sets from certain areas. We can start to think about using simulation data, right? So cardiac arrests are relatively infrequent, but we do a ton of cardiac arrest training and simulation. Can we be utilizing some of the simulation data as a proxy for the real life data? And so we see some of that. But I agree. There's going to be potentially limited transferability of some of this because of the data that's being put into it and the output biases that are going to occur.
Perfect. Thank you very much, Jared, for your presentation. And we're gonna see you in January in San Antonio next.
Yes, we're looking forward to seeing you there, if not before. Thank you all so much for your time this afternoon.
Bye. And now we're gonna move to the man of the hour. Our latest affiliation, it's with the Saudi Society for Simulation in Healthcare. Dr. Al-Attasi, are you present, please? Can you activate the camera? Hello, dear professor.
Assalamu alaikum.
Assalamu alaikum. So Professor Al-Attasi has graduated from King Saudi University, Training University of Toronto for anesthesiology, pediatric anesthesia, and cardiac anesthesia and critical care. Then he went and did an MBA from Stockholm School for Economics. He has over 26 publications in the field of simulation, critical care, quality, and patient safety. He is the Deputy Executive Director of the Perioperative Quality and Patient Safety in the Ministry of National Guard Health Affairs. And he's an associate professor at the College of Medicine, Al Faisal University at Riyadh in Saudi Arabia. He's a consultant of anesthesia and intensive care medicine at King Abdulaziz Medical City. And it is my pleasure to turn things over to you.
Thank you, Mohammed. It's always an honor actually to meet you and to meet all the group in Morocco. I'm absolutely honored and blessed actually to be part of this great activity. And I'm sorry I was able to catch from Dr. Jabin lecture ongoing. And maybe we're gonna move from the advancement of AI and the different modalities of simulation and how we can also make it handy to everyone into hands-on and what we need to do in order just to move the system forward utilizing the simulation. I'm gonna start with the sharing my slides, if you allow me, and I'm gonna start with this slide. So the first one is just the title, which is I thank you for that actually, Mohammed and Prof. Mahawi. So how we can use simulation as a lever for healthcare system transformation. This is a very fresh from the oven. This is a last week article. I'm sure many of you has been through it. So it's the title that's Benchmarking Progress in Non-Communicable Disease, a Global Analysis of Cause-Specific Mortality from 2001 to 2019. Okay, it's actually a very interesting study. I'm gonna start with that because it's just gonna show you where we're heading, honestly, in the ground of healthcare delivery. So what they did, they looked into the different reasons of mortality for, or the incidence of mortality for non-communicable diseases, which basically it's any end organ damage or injury, or failure, such as cardiac, renal, liver, and cancer diseases. And they compared the mortality before 2000 to two groups, 2000 to 2010, and from 2010 to 2020. That's what they did in a nutshell. And what they utilized a 51 country data coming from the WHO. And why those 51 countries? Because it's a high quality level of a data. Because as you know, with the WHO, many of the countries provide data, but they're not necessarily very well validated and of a high quality as per the regular standards of how you can do analysis. And they added for those 51 countries, another 12 countries and divided into their regions, okay? And they looked into mortality and they delineated that between two genders, male and female, and then age. And they looked, by the way, the mortality from age 0 to 80 years. Okay, so what did they find? By the way, after that, they used some kind of the statistical model to plot on top of this 51 and 12, which is basically 63. Okay, they plotted the rest of the countries, another 185 countries, and they looked also into the improvement or the change of the mortality, whether positive or negative, into those countries in comparison to the years before the 2000. So here's what they found, and that's what I found it very interesting. So from 2010 to 2019, the non-communicable disease mortality declined in 4 of every 5 countries in the world. Now, these improvements were not as large as the preceding decade for most countries, driven by smaller decline in mortality from multiple NCDs. Now, this study was conducted by the funding was the UK Medical Research Council, and I think it was from Imperial University College of Medicine. And actually, they did awesome work. Now, I actually looked into all these countries. And by the way, Morocco is there, Saudi Arabia is there, because they're part of the 185 countries. So I'm going to speak in just, since I'm representing the Saudi Society of Simulation. So we have to, definitely we need to do a lot of work in terms of the quality of the data we're providing. And actually, I think this is becoming a national mandate and working very hard on it to improve. But what was very interesting, our mortality improved from 2001 to 2010 significantly, but from 2010 to 2012 or 2011 to 2020, it stayed as is. It did not move a 0.1%. And this is what I found it very striking. So actually, there is a huge change in the healthcare delivery that actually materialized, and from clinical outcome perspective, and the patient have seen it after the millennium. But as we go in our progress and our delivery, it's clearly that we're losing momentum and we're kind of stagnant. And that's why we're going to ask how we are going. That's why we need the different modalities of doing interventions on the ground in the health delivery facilities to move forward. Now, this is, I don't think it's a strange. This is the 6 domains of healthcare quality, again, from Institution of Medicine, where it's the same institution that published To Err Is a Human, and that's, you're all aware about the article and the research that they published in 1999. And actually, by the way, they published another report in 2021, if I'm not mistaken. And guess what? We did not move forward in terms of safety. So the safety is still a major issue into the healthcare delivery and in terms of what we do on a daily basis. Now, the domains are safety, effectiveness, patient-centered, equity, efficiency, and timeliness. And simple, how we prevent doing any harm, how we make sure that whatever we're doing is actually intended for the appropriate purpose and outcome, how we look into things from patient perspective, how we make sure that all patients get the same management. And my colleague in the AI lecture, he just touched on the equity, and we make sure that it's actually it's available as a tool. A simulation with an AI is available for all the learners. How we provide the delivery whenever it's intended to in a timely fashion, and how we also utilize our resources in the best possible way and minimize the cost in a way. Now, this is the third concept I'm going to talk about here. So we talked about the need and demand and how we are stagnant. We talked about the 6 domains of quality, and we're all talking here about patient safety, patient safety is a major pillar of the quality in healthcare. This is a concept that's becoming more trendy in the last, I think, 10 or 15 years, but mainly now in the last 5 years, and at least in our country and in the Kingdom of Saudi Arabia, and it's part of actually the vision. So it's a value-based healthcare. It's an American concept in a way, and I think it's being utilized in many systems within the US and some also European systems as well in the West. So it's a healthcare delivery model that focuses on maximizing patient health outcome per dollar spent, rather than simply paying for the volume service provided. Okay, when you look at the definition, and it's a very simple mathematical equation. So the value equals health outcome that matters to patients divided by the cost of delivering those outcomes. When you look at the health outcome per se, it's not just survival, but it's a quality of life, it's functional recovery, it's patient-reported outcome, and patient-reported experience outcome as well. They call the PREMS and PROMs, by the way. And the cost is the total cost of the care across the full cycle of a condition, not just one episode or procedure. Now, having all this in mind, we actually truly have a challenge. Definitely medicine is increasing with complexity, and we can see with all the new interventions and new research that happening from stem cell perspective to the gene therapy to the CAR T cell to the very advanced robotic and surgical procedures. There is ongoing concerns about patient safety, and we just said that actually patient safety is still as harmful. We're providing, unfortunately, and that's very unfortunate, the healthcare system across the world did not learn over the last 20 years from the first report that came from the Institution of Medicine. We're still doing the same rates of harm and the same rates of preventable harms, to be honest. The third, there's a high level of staff fatigue and turnover, and that's very clear because the number of hours that our providers needs to put is becoming very significant. And actually, there are a lot of actions against that, which we're going to reflect actually on expense. On the other side, there is a demand to lower expenses while boosting efficiency. Now, if you look at the budget of healthcare in most of the Western countries of the G20, you're going to find it very, very significant. And it's not less than 10. Some countries goes to 20. There are some countries, and I can speak on behalf of Ontario as a province in Canada, they reach a 46 cents a dollar that's being spent in healthcare. You can imagine how much spending is that. And you cannot continue just moving up all the time, okay? You need to find a way to retransform and change what you're doing and make it more cost effective and efficient. So this all takes us to one simple rule that simple actually principle that the conventional training and the quality improvement over the last, let's say, 20 years, or precisely over the last 15 years from 2010 ongoing, it's falling short. So we need to do something, okay? This is why simulation probably comes handy. It's a more than skilled practice. Yes, it is a tool, Muhammad. It's a technique. It's not by itself something we go up to, but actually it can be very well used as a system improvement tool. And this is where the key factor, okay? Why? It's obvious, the safe space to test, fail, and fix. It's definitely build the shared mental models. And I think Jabin touched base on that. And this is where the culture has been changed or can be changed. And it generates data for decision, time to intervention and capture. And I think this is the key because you can always do it in a certain pace, on certain frequency, and measure your intervention and whether you performed well or not. So why simulation is a strategic lever? It reduces risks. It identifies latent safety threats before harm. So that's for prevention. And in many occasions, we brought them what we do before Hajj in the kingdom, where our teams simulate for 4 weeks, different scenarios, pre-commissioning in any healthcare institution. Another thing is improve efficiency and optimize workflow and processes. It accelerates adoption because it's smooth rollout for new technology, EHR, and policies. It's strengthening culture, again, by improving teamwork and speaking up climate, and deliver a return of investment, they call it ROI, where fewer errors, reduced waste, and better throughput. Like, now, evidence. I'm sure we have here like around 60 participants in the audience, and I'm sure I do not need to go over the is simulation proven help when it comes from safety perspective. So there are many ways. There are many literatures that prove that. So there are meta-analyses that prove patient safety in critical care, obstetric and surgery. Also improving the processes of testing to reduce events such as CLABSI and handover errors. And there are studies that show that in situ simulation reveal 80% of the latent threats. And there is also an evidence that it improve the return of investment by delaying the delays in the reducing delays in the OR and emergency department to ICU transfer time. This is the same thing, except here we're talking about the resuscitation. There is, good body of evidence that improves it by 20% or 12% based on which study you're going to read. And from obstetric perspective, the Cochrane article showed that it drops the harm or improve the patient safety by 30% at least. Now, so to use these cases for system transformation, we can do many things, right? So we can do safety drills. I'm sure that's happening in every healthcare delivery across the world now, such as Code Blue, sepsis, maternal hemorrhages, workflow redesign, ED triaging, overflow, discharge planning, helping in the technology rolling out, such as the HR module and devices, emergency preparedness, pandemic. I think COVID, every hospital that I'm aware of across my network, they actually simulated COVID, at least from the national perspective, across the board, from border to border. And disaster responses, you can use it for cultural team framework by having this interprofessional engagement and leadership engagement as well. And of course, you can help building scenarios and look at the cost and demand estimation. How do you implement it? First of all, I think we need to set the strategic aim, and that takes me back to the institution of medicine pillars or domains. So are you, because we're talking now on healthcare delivery as a whole. Yes, safety is the title of the conference, but we're talking about how we make simulation help transforming healthcare delivery. So you can decide about safety, you can decide about efficiency, timeliness, effectiveness, or readiness. You have to have a core team. And in the core team, we have the clinical team all the time, we have the quality improvement all the time, we have the simulation team all the time. But actually, what we need to also start to think of, and that's very crucial, the human psychology and how we can interpret the human factors and those personnel that they are expert in that domain in order just to help expediting the culture change. Rollout pilot in situ scenarios. That's what make a difference, in situ scenarios. And by the way, it has lots of regulatory affairs that you have to, regulatory constraints that you need to care for in order just to make sure that there's nothing will impact the patient in a negative way. Identify and fix latent threats, simulate and measure. So always start with measurement. Every intervention, pre-intervention, post-intervention, and then pre-usual interventions. Or scheduled interventions, then scale and embed into governance. This is a simple exercise. My colleague was talking about the AI. I actually used ChatGPT just to put a simple model, a very simple model. So those are very well-known safety measures that impact clinical outcome, right? And the way I built this cost-cutting model based on simulation training, it took me like 10 minutes to build, which is very interesting. Now, I'm not sure about the bias that within ChatGPT at the very point of time, but it's reasonable from our literature review. So you're going to have here the safety metric in the most left, then the impact of simulation training, the estimated cost of single adverse event, the reduction in adverse event by percentage based on evidence, okay, and the estimated annual cost. And by the way, the model based on 300 beds hospital. It's basically a medium-sized secondary hospital in a way. So the first metric is medication error. And the intervention by simulation, hopefully to reduce the medication-related adverse events. The cost is $5,000 per 30%. So the annual cost saving is around $30,000. From infection rate, I'm not going to go through the whole equation. The expected annual cost saving is around $37,000. That's for 25% reduction. Patient falls, 20% reduction. That reflects $30,000. Pressure injuries, 40% reduction, that reflects as 80,000. Readmission rate, it will by 50% factor of reduction of 35 readmissions rate per year. That will give us cost of saving by $63,000 US dollars. And lastly, surgical complication reduction by 30% or 12 complications per year. This gives us a cost saving of $72,000. Now, having the simulation and the feasibility of shall we not have a simulation lab. So this is the commissioning, or this is what you need to build the initial cost, the building and the simulation lab. When it's the construction, the equipment, the technology, the initial cost is around 800,000, and the operational cost per annum, which means staff salaries, maintenance, supplies, utilities, it's gonna around 200,000. So it's $1 million. Okay. Now, so from the $1 million, and if you assume that you're going to save $330,000 based on the first schedule, first table, this will make you losing around 670 in the first year. But from the second year after, okay, the cost is 200,000 while you're spending 300, or actually savings 330. That means that you're actually saving around 130,000 US dollars. So even if you think about it from strategic perspective, it's very business savvy, let's put it this way, to have a simulation within every institution. So let's talk about key performance indicators, because that's what the quality people live up with, or live up to, and they always think of. So based on the domains, you need to think about what you will need to do from safety perspective, improve the protocol compliances, to reduce the adverse events. From operation perspective, again, faster transfer, lesser cancellation, much better throughput. From culture perspective, improve the safety climate survey scores and improve speaking up behavior. And from a return of investment, again, cost avoided from adverse events and improved resource utilization. So the call to action of this, probably I think it's my last slide, is to, I think we all need to understand that implementing a simulation as a strategic system improvement tool is a key. And actually, for us, I think it's a mandate now. It's not an option anymore. We need to invest in sustainable infrastructure. That includes faculty space and protected time. And lastly, we need to integrate simulation into the quality assurance and quality improvement and the governance of every system. This is how we can make sure that simulation can be utilized as a lever for transformation. At the ground. One last comment before I actually conclude. In 2013, I actually had the honor to visit CHOP, which is Children's Hospital of Philadelphia. It's a very advanced statement. It always ranked first or second when it comes to pediatric medicine and pediatric surgery. I managed to, with the chief of anesthesiology and director of the OR services within the CHOPS hospital, we did the round inside the operating room. And he always told, and actually that day he told me, at any point of time, there are 2 operating rooms being renovated. And then I asked him why. He said, because we always need to move forward. And that was one single, principle that I actually learned that very day. So never be static in medicine. That's one. The second, every single OR they revamp or they renovate is actually simulation-friendly operating room, i.e., they can conduct simulation through the day, and it's always built within the operating room services itself, and it's always unannounced. So they just call the code, they just do the activity or the drill for different specialties in situ. And I found that very, very interesting in 2014. I think now it's a must in 2025 that we need to actually follow their commands and their roads, and just making sure that simulation, it's in every corner as a concept. And a tool for improvement is in every corner in our healthcare delivery facilities. Thank you very much, Mohammed.
Thank you very much, dear Professor Atassi, for your amazing presentation, the least we can say, and for sharing with us the latest data studies, less than a week. So this is something. I will just ask you one question, because the subject is something that's very, very big, and it has a lot of implementation everywhere in the patient safety and simulation field. But if you could redesign a hospital or a health system entirely around simulation, what would be the first structural change you will do?
that's harder than what it sounds, to be honest, Muhammad.
Yeah.
Definitely. I think within every facility, it depends. Honestly, I'm gonna speak now as just an administrator. Okay, it depends how much budget I have. Okay, I will make sure that I have a simulation lab integrated within the hospital, and if my budget allows, I will make sure that I have multiple simulation labs embedded within different streams of services. So for perioperative stream, we got one. For medical or critical care and urgent care, we have one. Okay, for obstetric and gynae, we have one. And it's, by the way, here, it's not about the technology that I'm investing. It's about the mindset and the personnel and the human psychologist or the human factor experts that embedded within my organization, and how I'm going to make sure that within the very backbone of my institution, the simulation is embedded for every harm happening to prevent it from happening again, God forbid. Thank you.
Thank you very much. And Armando Romanos here said, thanks, amazing presentation. For me, it's also important the huge engagement that simulation generates in teams. And we definitely all agree with this. I will take a moment to acknowledge and give an announcement. The official signature for the affiliation between the Saudi Society of Simulation in Healthcare and Morocco Sim will be taking place on the 21st of October in our next event of the Morocco Sim. It's the Sim Cup on the 21st of October. Thank you very much. Thank you very much to all the speakers, and Dr. Alami, it's all up to you.
Many thanks to Dr. Derwish and to our distinguished speakers for this excellent final session. We will move now to the closing remarks. It is my honor to invite Professor Mohammed Mohawi, Professor of Anesthesiology and Intensive Care, Chief of the Trauma Center in Casablanca, President of Morocco Sim, and a true pioneer of simulation in our country, to deliver the closing remarks.
Thank you, Mimette. Thank you for all. What a journey. It was so inspiring, so insightful, so amazing. So, folks and dear colleagues and dear friends, as we close this enriching edition of Patient Safety 2025, which stands for the second International E-Conference on Training and Simulation for Patient Safety, I would like to sincerely thank all participants for their commitment and active engagement throughout the day. Your energy and contribution have turned this event into a true collective success. But allow me to say something very important. I want to give a special recognition to our board members. My thoughts go to Professor Fotassi Mariam, our Vice President, to Busharib Yunus, our Vice Secretary General, to Derwish Mohammed, Treasurer, to Baghdadi Siham, Vice Treasurer, and to Professor Yaman Ma'amar, Professor Mikawino, and the Master, Mr. Lubaris Mohammed Ala. Those members, they are truly working hard with dedication and vision to ensure the success of every initiative we undertake. I think their constant support is one of the pillars of our society. And you may guess, I have forgot a person very important for our board. So last and not at least, allow me to express a particular word of gratitude to our Secretary General, Dr. Alami Younsi Mariam. I will reveal you a little bit secret. Despite recently facing a health issue, being admitted to the hospital, and with the joy of expecting a baby in just a few days, she still chose to lead this day with remarkable dedication, grace, and professionalism. Thank you, Mimette. Her example embodies courage, commitment, patience, and we are deeply grateful. Thank you a lot, Mariam. Thank you very much.
Well, thank you very much, Professor.
No, it's okay. Just 1 minute. To be back to our journey, just 1 minute. From our discussions, and exchange, several key recommendations have emerged today. I think we have to focus about strengthening patient safety throughout wider integration of simulation in healthcare training. The second point, to promote interprofessional collaboration as a driver of safer care. The third point, we have to encourage innovation, including the use of digital tools and artificial intelligence in both education and practice. Fourth point, we have to sustain international collaboration and networking, sharing experiences across borders. And the last point, to place patients and the safety at the very heart of every healthcare reform and educational initiative. And finally, our journey continues, and I'm delighted to announce two major upcoming milestones. The first one, SimCup 2025 in Rabat this October, with more than 20 multidisciplinary competition with our famous slogan, simulate, compete, learn, and repeat. And for sure, the very biggest major event, HTIC 2026, which will be this year coupled to the first edition of the Pan-Arab Conference of Simulation for Healthcare, and which will be hosted in the historic city of Saleh, a new step in our collective adventure. Once again, thank you very much for being part of this event. Together, we continue to shape a culture of safety, quality, innovation in healthcare. Thank you, Mimi.
Well, thank you very much, Professor Mouhaoui, for this thoughtful and very inspiring closing remarks. As our day comes to an end, I would like to sincerely thank you all, our affiliated societies, as well as our speakers, chairs, and participants from around the world for making this event such a success. Through the day, we have journeyed from errors to excellence with the power of simulation, the strength of integration, the wisdom of human factors, and the vision of innovation. I'm also happy to close by announcing the next edition. Let me share my screen. It's the International E-Conference for Patient Safety 2026. Till then, stay safe and keep pushing the boundaries of patient safety. Goodbye and see you next year.
Bye-bye.
Thank you.